is here, and I hope we can start now. We will start at 5:08.
Yes.
Good evening, everybody.
Good evening.
Hello. Good evening.
Good evening.
Good evening.
How are you?
Kader bhai,
Hi.
assalamu alaikum.
Islam.
আমাদের সেকেন্ড কি পার্থপ্রতিম মজুমদার না?
Yes.
ফার্স্ট কাদের, সেকেন্ড পার্থপ্রতিম মজুমদার, থার্ড প্রিয়া, ফোর্থ পার্থ বিশ্বাস, and lastly S Natarajan.
Yes, sir.
Oh, Deepak, welcome.
নমস্কার দাদা।
কেমন আছো?
আনমিউট করো। হ্যাঁ
কেন?
হ্যাঁ ঠিক আছে। Deepak has already joined.
স্যার আসসালামু আলাইকুম স্যার।
আসসালাম।
ম্যাডাম নমস্কার ম্যাডাম।
হ্যাঁ নমস্কার। ভালো আছো? তোমার মাথার দিকটা একটু করো, মাথাটা কেটে যাচ্ছে।
Everybody looking very nice.
ঠিক আছে।
Hello sir. Sir, we are waiting for you.
মাথাটা কেটে যাচ্ছে। এইভাবে রাখো।
Okay, fine.
স্যার তো দুইটি করে গেল।
Yes sir.
Good evening.
Good evening. Hello sir.
Okay, S Natarajan.
Good evening sir.
Good friend.
Hello.
Best friend. Welcome.
Welcome. How are you?
Yes, fine. I'm fine, Natarajan.
Yesterday, Dr. Shyam was upset. I said, don't worry.
Yes, sure. And as you have given us some inspiration, that's why we are again today. Otherwise,
Hello Amir.
sure. Yes,
Hello
Amir.
Dr. Amir.
Amir, yes.
How are you?
Assalamu alaikum.
Fine.
Hello, everybody.
How are you?
Hello everyone. Hi.
Hello.
So sir, we are talking with our own language. So there are some foreigners. So definitely. So good evening.
Hello.
Dr.
Hi,
Majumdar is coming. Partho Pratim Majumdar has already joined. Yes, welcome. Good
Hello,
evening.
sir. Hello, good evening, sir.
Yes,
Hi.
good.
Hello Dr. Partho.
Hello, sir.
And also good evening, Dr. Priya.
Yeah.
Hello, good evening.
Good evening. Good evening.
How are you?
Yeah, I'm fine, sir.
So I think Dr. Partho Vishwas will join 10 minutes later
Right.
because he has another webinar.
Hello.
Okay.
Madam,
Hello sir.
madam.
Hello Natarajan sir. How is
Yes,
Achi?
your madam is.
Achi is fine.
Yes.
Yesterday,
Yes, Natarajan. You are so busy with all the webinar in India. Almost all the day you are in some of the webinar.
yeah, every day free webinar.
Yes. Today you have 3 webinar. Okay, fine.
Natarajan sir is also attending some social webinar. So
Yes.
a very social webinar, and he is very important person in different societies.
Probably
Even
the
not
social
only the
work,
doctors.
social work will take Natarajan in such a way that once we can see him as a minister of India.
Yes.
Dr. Rava, madam,
Yes.
Hi, Natu.
how are you? Nice to see you, madam, again.
Natu is a great leader.
Yes, he's a
I
great
will tell.
Hello,
I
madam.
will tell to everybody.
Yes.
Hello.
How are you, Amar?
Hello.
Very well.
Good.
I'm
Dr.
fine.
Natarajan, I want to ask you one
Fine.
thing.
Yes,
You're
ma'am.
used to so much of traveling. How come now you are feeling after having stuck in this COVID situation?
Actually, I don't know how I have become first 2-3 months enjoying sleeping, watching movies.
Good.
Yes.
And
It's
then,
good for you.
and second, I was wondering how can I sleep without a bed in the plane?
Absolutely.
Still you're carrying on.
2 days
Still you're
I was
doing lot of
traveling. Then I decided in April first
Yeah.
week only, I gave a talk, COVID times, happy times. So everybody was
Yes,
happy
sir.
with me. How can you give a talk, happy times?
Yes.
Yes, sir.
What is it? Happy time is I'm 24/7 with my grandmother.
Yes.
So that 102-year-old, and then I'm interacting with her, even though she's too old. But and then learning some yoga exercise, and then
Very good.
interacting with the whole world. Actually, I started my webinars on March 27th.
Okay.
Ecuador with Brazil, then
Very
Chile,
Good.
Guatemala, so all that. So it goes on. Now all over the world I am there. Now I'm going to be on 29th to the
COVID has given us some idea and some scope that without plain fear, we can see everyone every night or every day in the webinar. And
Yes.
now it is a global village, isn't it? We
Correct.
can see here, Indonesia is nearer, India is nearer, Pakistan is nearer to us, and everyone is today in the screen. So if we talk by going everywhere by plain fear, we would spend a lot. But
Correct.
COVID has given this economic help
Opportunity.
to us.
Yeah, yes, yes.
Yeah, sure.
So,
I agree.
Shams.
can I tell about the program?
Yes.
We will start at 8:05, and first I will introduce all of you in front of the attendee, and then our host and chairperson will start the program, and then Professor Abha Madam, our guest of honor, will tell something. And then we'll start our webinar. Our first speaker will be Professor Kadir. And then we will discuss. Each speaker will get the 10 to 12 minutes, highest 12 minutes. We have to take care of that timing, please. And then after first speaker, then we will have 5 minutes for discussion. If you have any questions, and if anybody, we can discuss about that matter. And the second speaker will be Dr. Parthopratim Majumdar. And after his speech, then we will discuss. And third speaker will be Dr. Priya Narang, and then our discussion. And after Priya Narang, if Dr. Partho Vishwas will be available, then he will speak. And our Professor Natarajan will be there after Partho Vishwas' speech. And this is the planning actually. And we have a lot of residents. They have almost 10 to 12 questions. They have already asked through our different pages. So if you have time, then we will discuss over there. And we have almost 10 questions from each speakers. So we have already 10 questions we have collected. So we will discuss later on. And if we will get time, then we will discuss.
Yes.
Do you have any comments, like any plan or anything?
Or
else?
any suggestion?
Suggestions?
I think it looks perfect. That's fine.
Yeah.
Okay, fine. What about Natarajan? You will be a whole time with us. You will not be able to leave us.
I'm here. I'm here.
Okay,
Hello, Dr.
fine.
Natarajan. Good evening.
Good evening. Hi. How are you?
I'm good. I'm good.
So how was the eye donation fortnight today? With the
It's going on actually. It's on the other side, and today I'm behaving like you.
Google time, it is 8:05. It means
Okay,
5
so-
minutes past 8 Bangladesh Standard Time. And
Okay,
India,
so we can start.
yes, we can start. I hope our moderator, Dr. Shams Muhammad Noman, he will introduce all the panelists, speakers, president and host, and also our guest of honor. I will request Dr. Shams Muhammad Noman to start the introduction.
আসিফ সাহেব ওই যে ইয়ে করেন আপনার পেজ থেকে ফেসবুকে দিয়েন ঠিক আছে হ্যালো ওকে
Okay.
हर इंसान की तमन्ना होती है।
The slide is visible?
Yes.
Yes.
Honorable host and chairperson of this session, honorable guest of honor, honorable chief guest, and honorable panelists and speakers. Welcome to the session, The War Against Trauma, Episode 1. Why it is war actually? Why this trauma, we are taking it in war? Because it is less cared, it is a time-consuming management, outcome is variable, and sometimes anesthesia is a great factor. Possibility of infection, facility is not available each and everywhere, like investigations and also management. So I am delighted to introduce our chairman and host, Professor Muhammad Sharfuddin Ahmed. He is professor and chairman, Department of Community Ophthalmology, Bangabandhu Sheikh Mujib Medical University. He is also president, Ophthalmological Society of Bangladesh. He is the president, Bangladesh Community Ophthalmological Society. He is also the president, Oculoplastic Society of Bangladesh. He is the first Secretary General of Bangladesh Medical Association. He is also the president of Bangladesh Ophthalmic Research Forum. It's my great pleasure to introduce in front of you Professor Aba Hussain, our leader. She is director cum chief consultant of Ophthalmological Society of Bangladesh Eye Hospital. She is president-elect Asia Pacific Academy of Ophthalmology. She was past president SARC Academy of Ophthalmology. She was past president Ophthalmological Society of Bangladesh. She was the founder president of Bangladesh Community Ophthalmological Society. She is the receiver of prestigious Alim Memorial Gold Medal from Ophthalmological Society of Bangladesh, and she is also a proud receiver of Apaw Achievement Arthur Lim Award. I am really honored to introduce in front of you our special guest and speaker, Professor S. Natarajan. He is the Padma Shri awardee, very prestigious award of India. This award is one's dream actually. He is the chairman and MD Aditya Jyot Eye Hospital India. He is the president Organized Medicine Academic Guild, past president All India Ophthalmological Society and Ophthalmic Trauma Society of India. He is the Secretary General Global Eye Genetics Consortium, the Board of Trustee International Council of Ophthalmology. He is also the president of Asia Pacific Ocular Trauma Society and Shankar Netralaya alumni. I am introducing Professor Rajesh Sinha as a panelist. He is honorary treasurer, All India Ophthalmological Society and SARC Academy of Ophthalmology, most responsible post. He is professor and Cornea, Cataract and Refractive Surgery Service, RP Center for Ophthalmic Science, All India Institute of Medical Science, New Delhi, India. I am introducing my friend, Dr. Amir Awan from Pakistan. He is consultant ophthalmologist and retina specialist, Shifa International Hospital, Islamabad, Pakistan. He is associate professor of ophthalmology, Shifa College of Medicine, Pakistan. I am introducing Professor Deepak Kumar Nag as panelist. He is professor and head of the Department of Vitreous, National Institute of Ophthalmology and Hospital. He is the chairman, Scientific Subcommittee, Ophthalmological Society of Bangladesh. He is a proud receiver of Motin Gold Medal, Asia Pacific Academy of Ophthalmology Distinguished Service Award. I am introducing Dr. Tariq Reza Ali as a panelist. He is Associate Professor, Vitreous, Bangabandhu Sheikh Mujib Medical University. He is the Secretary General, Vitreous Society of Bangladesh. He is a proud receiver of Motin Gold Medal, Harun Memorial Award, and Fazlullah Memorial Award of Ophthalmological Society of Bangladesh. I am really delighted to introduce Dr. Gitalisa Andriani Adriano, my friend. He is the Vitreous consultant, Department of Ophthalmology, Faculty of Medicine, University of Indonesia, SIPTO, Mangunkusumo Hospital, Indonesia, Jakarta Eye Center, Indonesia. I am really honored to introduce in front of you Professor Dr. Partho Vishwas as a speaker. He is director, BBI Foundation, Kolkata, chairman, Scientific Committee, All India Ophthalmological Society. He is chairman, Academic and Research Committee, All India Ophthalmological Society. He is the proud receiver of national and international awards like Colonel Rangachuri Award, ESCRS Best Paper Award, All India Ophthalmological Society Uveitis Best Paper Award, EPCRS Video Award, and BOA Gold Medal Award. I am also delighted to introduce Dr. Parthopatim Datta Majumdar as a speaker, very favorite to our Bangladeshi people. He is also Bengali. He is the Senior Consultant, Department of Uvea and Intraocular Inflammation, Shankara Netralaya, India, founder cum chief editor of popular ophthalmology portal www.uoptha.com. It is also a very favorite website for our ophthalmologist. And he is the proud receiver of Natarajan Pillai Award and K.R. Datta Award for his academic excellence. I am really honored to introduce in front of Professor Abdul Kader as a speaker. He is the Secretary General, our favorite leader of Ophthalmological Society of Bangladesh. He is Professor of Cornea, National Institute of Ophthalmology and Hospital. He is the proud receiver of Fazilot Memorial Award from Ophthalmological Society of Bangladesh. And this is Dr. Priya Narang. As a speaker, he is very famous, you know. He is Director, Narang Eye Care and Laser Center, Ahmedabad, India. Chief Editor of the book, Anterior Segment Repair and Reconstruction. He is the gold medal winner from IIRSI and gold award from the Indian Journal of Ophthalmology for his papers and academic excellence. And he is writer of different books. I will tell later on. And this is me, Dr. Shams Mohammed Numan. I'm the Senior Consultant and Head of the Glaucoma, Chittagong Eye Infirmary and Training Complex. I'm the Member Secretary of Bangladesh Ophthalmic Research Firm, General Secretary of Ophthalmological Society of Bangladesh, Chittagong, and I'm the Council Member of SARC Academy of Ophthalmology. So I welcome all in this webinar, and I think we will start our session.
Okay.
I'm stop sharing.
Yeah. Okay.
So now I am requesting Professor Abdul Kader. I'm requesting Professor Sharfuddin Ahmed to tell something as an introduction. Professor Sharfuddin Ahmed, the floor is yours.
Thank you, moderator, Dr. Shams Mohammed Noman. It's my pleasure to be with you as a chairperson and host of this webinar, which is in such webinar that war against trauma. War we have seen as we are in the same region. We all know Bangladesh, India, Pakistan, Nepal, also China. Everywhere there is war. But this war against trauma, I think here this webinar will give us such idea that in war there is the many lives become, many one die. But in this trauma, the death of the eye means loss of vision. So this type of webinar will help us to restore our vision. Our guest of honor, and she's the panelist, and also she is the President-elect Asia Pacific Academy of Ophthalmology. We welcome him in our webinar. And next special guest is Natarajan and also speaker. I welcome you in this webinar, and I hope other speakers and panelists whom our moderator has already introduced, and I hope India, Bangladesh, Pakistan, Indonesia, India, all are together in a global village. We hope this type of webinar will be continued, as because you have seen that this is the episode number 1. I hope our speakers and our panelists will enrich our all the ophthalmologists as well as our residents who are participating in this webinar. In future, all other things like what is the manifestation of corona in different or ocular manifestation of corona in different countries, in Bangladesh, in India, or in other countries like China or in Europe. We can have an webinar in future like that. Today, I hope the traumatic cataract, trauma to the cornea, retinal detachment, the trauma to the iris, everything will be discussed in such a manner that it will not be only beneficial to our ophthalmologists, it will be very much beneficial to our future ophthalmologists, that is residents or trainee who are now working in different institutes of this region. We are now living in a global village. So the latest informations about all treatment and diagnosis of our ophthalmic diseases, that will be easier to everyone. I will not take much more time. Again, I welcome all the speakers and panelists and all the attendees who are with this webinar. I hope you all will be free from COVID and you will live long with a healthy life. With these few words, thank you very much.
I'm requesting Professor Abha Hussain to tell something before starting our webinar. Professor Abha Hussain, madam, please. Hello.
Yes, madam.
Thank you so much, Dr. Noman. It is really a very great honor and pleasure for me to be here today and address you. My heartfelt thanks to Professor Sharfuddin, chairman and host of this webinar, for inviting me to this wonderful and outstanding webinar. This webinar is so much great as because Professor Natarajan, he is the leader and he is really a very great leader, as because just few days back I was in that platform, that is ICO launches the International Leadership Development Program, whereas Natarajan is the person who is the main coordinator, and he coordinates in such a way the great leader all over the world was there, including Ivo Cocker and also the president of the ICO. So I am really very happy, and thanks to Professor Natarajan. Then yesterday we could not start due to the internet problem, server problem, and all of you were waiting there. So thank you so much for coming here today. There is a great session, that means 5 panelists, 5 speakers, and 1 moderator, 1 chairperson, and 1 guest of honor. In such a way, the war against trauma will start. And this trauma, this is very much in my heart from the very beginning of my career, from 1981. And when I was in National Institute of Ophthalmology at that time, the place where all the emergency, ocular emergency, have referred to that institute at that time. Nowadays, there are so many institute and emergency occurs all over. But at that time, in 1981, at that time, it was only the National Institute of Ophthalmology. And I was there for 17 years. So it is very much, for me, it is very great thing that I have seen lot of trauma from the very beginning of my career. And the thing which hurt me very much, that is the very, the baby, the mother, when they are feeding their baby, breastfeeding, at that time, in the village, they are gossiped together and just covered with this cloth, the shari, and the hook of the blouse that enter into the eyelid, lower eyelid, and just take out the lid. And what a terrific condition. That is a 3-month baby, 6-month baby, like that. And also there are some intraocular foreign body. Nowadays, it is very easy to remove all the intraocular foreign body, but at that time, there was a giant magnet. It was so giant and it was so heavy that it was really impossible for me to push. And there are somebody to push it, and I only just lowered the magnet part, the head part. And in this way, we have started. So this name, the appropriate name, that war against trauma, and this trauma still going on day by day in every part of the world. Somewhere, some in smaller way, but in our country, in India, in Pakistan, in Indonesia, and everywhere, we know that there are so many varieties of trauma. And this is a agricultural region, and the harvesting time, there are trauma due to paddy tree. So today's session is such a way uh, they will uh, present, the presenter will present in such a way that is the traumatic retinal detachment, very important thing. Traumatic retinal detachment. The younger generation, the myopic eye are very much vulnerable for traumatic retinal detachment, and also the other also. So traumatic retinal detachment will be presented by Professor Natarajan, and Partho Bishwas will present traumatic cataract, and other thing, Professor Kader will give presentation on basic corneal injury. This is another important corneal injury, as because this is the more emergency. As soon as it happen, as early as repaired by the cornea specialist or the surgeon, that means it will heal very nicely, clearly. So there will be no edema, chances of edema. And if it delays, then there will be very great complication will occur. So it is very, very, ocular trauma is always an emergency, and we should deal in that way. And I understand, I believe that Professor Sharfuddin and Dr. Noman, they will already design this session in such a way that everything will be very much helpful for our resident, for our colleague, for our all the participant we will be listening. Here are, I am seeing that Professor Deepak is here, Dr. Gita Lisa is here, Dr. Amir, Dr. Priya, Dr. Partho Pratim, and Partho Bishwas. All are very great surgeons, and wish you a great success. And we will learn from you. With this few words, I would like to thank you again for giving me the opportunity to say in front of you. And thank you so very much. Thank you.
Thank you, Professor Abha, Madam, for your encouraging speech. Now we will start the session. I'm requesting Professor Abdul Kader to start his presentation on basic aspects of penetrating corneal injury. So, Professor Abdul Kader, the time is yours. You can start.
Good evening, everybody. Am I audible?
Yes.
Yes.
Thank you. It is my great pleasure to be the first soldier in the war against trauma. Honorable Chairman to the session, panelists, learned speakers, and moderator. Very good evening, everybody. I like to talk next few minutes basic aspect of penetrating corneal injury. That is, it is just a very introductory lecture. What is penetrating corneal injury first? It is a partial or full thickness laceration of the cornea by a sharp weapon at the site of impact, it is a ophthalmic emergency. Why it is ophthalmic emergency? It is, there is a huge impact on eye as well as our life from this injury. The first effect on the eye, effects on eye, the ultimate result is corneal scar. Cornea become opaque. This reduced corneal transparency, there is cosmetic deformity, and there is alters corneal unique shape. There is a flattening of the cornea leading to hypermetropia as well as astigmatism. And there is uneven corneal surface, hampers the normal resurfacing of the cornea by the tear film, and ultimately structural weakness to some extent by the penetrating corneal injury. So what are the general problem by the penetrating corneal injury? There is a loss of vision from mild to moderate to severe loss of vision due to scarring of the cornea. And another important thing is cosmetic deformity. There is an opacity of the cornea leading to cosmetic deformity. This visual loss and cosmetic deformity leading to huge impact on psychological, social, as well as economical impact. So what are the impact in life? There is a huge impact. At first, there is psychological impact, that is always suffering from anxiety and adaptation to a new and unfavorable reality from the injury of the cornea, and sometimes loss of their job, career opportunities, and sometimes need to the changes of the major careers, and there are financial loss, and this leads to the alter their lifestyle, and there is increased risk of further injury, and sometimes there is permanent physical deformity. These are the impact on life. And what are the expectations from the patient side? The expectation regain of the good vision as before, and attractive beauty as before, as well as expression, good expression as before. So what are our aim in the management of corneal injury? The ultimate aim is spherical cornea with minimal scar. Do not do any harm. That is refractive closure of the eye. There are 4 strategies in the repair of the corneal injury. Any type of injury, there are 4 strategic plan. Number 1 is prevention of further trauma by protect the eye with rigid shield in case of open globe injury, and operate the injured eye as early as possible. And second important thing is minimize the risk of infection after trauma by introducing broad spectrum antibiotic or antifungal or other antimicrobials, and operation as early as possible. This leads to minimize the chance of infection. And third important thing is the psychological trauma. Prevention of psychological trauma by gentle and frank counseling. Counseling is very much important in the management of injury. And last is the minimize legal problems. Sometimes injury occurred by the homicidal attack or accidental attack. So proper documentation as well as filling up the medical forms to minimize the legal problems. So what are our plan of management, ways of management? There are 4 stages. Initial management at the site of injury or attending the first physician, and then counseling, definitive management, and finally the rehabilitation. So what are the initial management? The initial management, taking a brief history, in short, the time, type, and severity injury, and other circumstances. And a specific question must be asked to rule out the foreign bodies, chemical exposure, as well as previous ocular surgery, especially corneal surgery. And visual acuity must be measured by the attending physician or attending doctors. Do not flush the injured eye in case of open globe injury. Do not instill any drops or any other things. over the eye. Do not rub his eyes. Do not remove the object. Try to remove the object out of the eye and rule out the intraocular foreign body if possible. The first thing is life-threatening condition, treat first, and the ocular injury. And now, what is the therapeutic plan at the site of impact? The reassure the patient, relieve the pain and anxiety, as because pain causes squeezing of the eye and expulsion of the intraocular content. So pain relief and anxiety is the prime importance at the site of injury. And then to prevent the further injury by protecting the eye shield, by applying the eye shield, not use the patch. Patch causes the pressure over the eye and expulsion of the intraocular content. And sometimes need tetanus prophylaxis as well as to prevent infection. We must use the intravenous antibiotic or oral ciprofloxacin like antibiotics. And we make the plan the patient fasting or not. If it is under general anesthesia, you must pay patient in fasting condition, and referral of the ophthalmologist is the first advice to the patient. The definitive management done by the ophthalmologist is a tertiary eye center. Here all the facilities for the repair of the corneal injuries available. A detailed history is taken here and specific question as before. So what are you evaluate an eye? A brief history and then naked eye examination to see the patient severity of the patient, and slit lamp examination is a must. The direct illumination to see the what type of injuries occurred, what are the extent, what are the circumstances, what are the condition of the injury, what is old or newer fresh condition. And if there is a question regarding it is AC form or not, then we do the saddle test to confirm. Sometimes we need some investigation like ultrasound, biomicroscopy, X-ray, CT scan, MRI, base scan, and sometimes we need blood sugar as well as a random blood sugar if there is indicated. And the treatment option. How the treatment? Two types of treatment in penetrating corneal injury. Number one is non-surgical treatment, and second is the surgical treatment. Non-surgical treatment are, number one is antibiotic with cycloplegics. If the laceration is not full thickness, it is self-sealing, and then antibiotic and cycloplegic is enough to heal the cornea properly. And second is bandage contact lens, and third is tissue adhesive glue. In case of lamellar laceration, sometimes not full thickness. If there is full thickness less than 2 millimeters in size, we can use by bandage contact lens. The bandage contact lens should be low water content and stiff fit. Stiff fit for that reason is compact the pressure over the cornea to proper apposition by the bandage contact lens. Another is tissue adhesive. If bandage contact lens is not sufficient, not properly seal the wound, then we use fibrin glue or cyanoacrylate glue. If the perforation is less than 2 millimeter size or full thickness, and if persistent leaking through this small wound, then we use the tissue adhesive glue. And after application of the tissue adhesive glue, we use the bandage contact lens. And the surgical indication of surgical management. If laceration more than 2 millimeter size, and in case of sealed in any size of injury, displaced wound, loss of corneal tissue, and laceration with iris or lens incarceration, and the wound not amenable to treat with bandage contact lens as well as tissue adhesive, then we need to repair of the corneal injury. And first important thing is anesthesia. Good anesthesia is mandatory. If anesthesia is not good, eyeball is squeezed and intraocular content will be expelled out. So anesthesia is the very much important beginning of this repair. That is, general anesthesia is a good, then if not possible, sometimes we use the perivalvular anesthesia, and very few cases topical anesthesia sometimes used. Now, what is the indication of local anesthesia that is possible by local anesthesia? That is corneal or limbal injury laceration less than 6 millimeter. And in case of form anterior chamber, as well as there is no RFPD and very much cooperative patient, then we can use for local anesthesia. And another important thing is exposure of the injured eye. It is very much important. good anesthesia is mandatory here. We have two procedures, one by lead speculum, another is lead suture. Very much careful in this stage, as because any undue pressure over the eye leads to the chance of prolapse of intraocular content. This is very, very harmful for the patient. So exposure of the eye, exposure of the injury is very much important. Now there are surgical considerations. There is different types of injury needs different types of surgery. Number one is full thickness corneal injury. If there is full thickness corneal injury, there is eyeball is flattened. We make it spherical. Why the Rossi and Hayes technique is a very important thing here. That is, peripheral suture is larger and deeper than central. In this way, peripheral cornea become flatter and central cornea become stiff. And second important thing is corneo-scleral wound. Here, the repair start from the limbus. Limbus is the landmark here. You start initial suturing start at the limbus, and then corneal injury repair, and then scleral injury. Scleral injury step by step. That is, explore and then close as you go like fashion. And stellate wound, it is very much important. It is a two procedure, bridging suture as well as inner suture. And another important thing very much devastating is the tissue loss. If there is corneal injury associated with tissue loss, there is spar sting suture. We can close the gap and sometimes use the tissue adhesive glue, and sometimes we use the patch graft. And that is keratoplasty. And suture materials we use in the corneal ocular injury repair is cornea by 10 or monofilament or 11 or monofilament nylon. And in scleral wound, it is Vicryl or polypropylene 80, and iris in by 10 or polypropylene, and conjunctiva by Vicryl or 80 silk. And suturing principle. The suturing principle is very much important. It will be perpendicular to the laceration, and 90% depth in each side and equal depth in both sides of injury, and length must be 1.5 to 2 millimeter. It depends upon the location and size of the injury. And another important thing is suturing technique. The suturing technique is the knot technique is 2:1:1 or 3:1:1. 3:1 is more secure, but burying is sometimes very difficult. So all the suture must be buried inside the cornea. And another important thing after repair of injury is the formation of anterior chamber. The first choice is balanced salt solution. If balanced salt solution not properly form the anterior chamber, then we can try the second choice is air. If air is not sufficient, then ultimately third choice is gel, the ultimate choice. And we must form the anterior chamber by the separate paracentesis wound. So the basic steps of corneal injury repair is anesthesia, exposure of the eyeball, and exploration of the wound, toileting of the wound, reposition of the iris if needed, and closure of the wound, and formation of the anterior chamber, and at last the subconjunctival antibiotic and steroid injection. And postoperative management is antibiotic, steroid, control of intraocular pressure, and promote the reepithelialization with the artificial tears, vitamin C like drugs. And suture removal in case of adult, it is 3 months onwards. In children, 1 to 2 months, within 1 to 2 months, and infant, it is earlier, within few weeks after repair of the corneal injury. And in sometimes there is needed early repair, early removal of the sutures, like loose sutures in suture abscess, corneal ulcer, and in case of vascularization indicate the healing of the wound. And the fundamental role of injury repair is, if you cannot, you do not do. And the ultimately is visual rehabilitation by spectacle lens. If spectacle lens is not sufficient, there is irregular astigmatism, we can try the RGB contact lens, and then astigmatic keratotomy sometimes needs laser surgeries, and ultimately if there is big opacity, large opacities, then we do the keratoplasty. So ultimately, there is no proven recipe for corneal injury repair of ocular injury repair. So every ophthalmologist must be an trauma expert. So this is my very, very basic aspect of corneal injury repair. Thank you very much for patient sharing. Good night.
Thank you, Professor Abdul Qadir, for your nice presentation. I'm requesting all the speakers to take care of their times. Can you please stop your sharing?
Yes.
Professor Abdul Qadir.
Shams Muhammad Noman, we
Yes, sir.
welcome Dr. Partho Bishaj. He has already joined with us. Even though he has already told us that even though he's late, I think it is late. It is better late than never. Partho Bishaj, it is okay.
Hello.
Yes,
Hello.
welcome. Welcome.
Is there a late fine, sir? Is there a late fine or a late penalty?
Yes. Late fine will be
Thank
taken
you.
from India in the next 21.
Okay. I think welcome, Professor Partho Bishaj. Thank you for coming. I think now we can discuss on these measures, the corneal injury, basic aspects of corneal injury. So I'm requesting Dr. Ajit Sinha to tell some comments about this speech or presentation.
A very good evening to all of you, and thank you, Dr. Noman, for including me in this webinar. And before I start the, my comments on this wonderful talk that Professor Qadir has given, I would like to, pay my regards to Professor Ava Hussain ma'am and Professor Sarfuddin sir. They are the pillars of ophthalmology, not only in Bangladesh, but all over the SAARC countries and Asia Pacific. So thanks to all of you. I think it was a very nicely covered presentation by Professor Qadir, and I'll be very crisp and short in just adding a few points that I felt that, what I can. And I will just go on the basic principle that Professor Qadir had told, and that was minimize scarring, and that is very essential. And for minimizing scarring, it is very essential to have a proper edge-to-edge apposition. Because if the edges are not apposed properly, the scar size will increase. That is one. The second point is that we should try to avoid getting that part vascularized, and that at least in the central part, and that vascularization increases the thickness of the scar. So in order to reduce vascularization, one should be absolutely careful that there is no iris tissue adhesion to the wound. So that should be released. Third thing, Professor Qadir had very nicely mentioned, avoid infection, and that infection also increases vascularization. So one should be very careful. And for preventing infection, there are two major things. One is that if the sutures are loose, then they can incite vascularization, and that can come from periphery and then come in the center, and that can create problems. The second thing is that if there is any leak in the wound, that can cause infection. Then of course, sir had told psychological trauma. Yes, that is very much there. So we should prevent that by counseling, sir had told. The second thing is appropriate management, and it is an ophthalmic emergency. So we have to be very fast in our actions so that we can minimize damage. And one thing I would just like anterior chamber maintenance, sir had mentioned, I will just differ on that I would not use viscoelastic, any gel substance for maintaining, because there's risk of increase in IOP post-op. So we should avoid doing that. And another thing that sir had mentioned, that this is seen many times in children. And sometimes these children are in the amblyopegenic age group. So once again, a proper visual rehabilitation is something which is very, very important. And that proper visual rehabilitation, if the scar is coming bang in the center, then many times RGP contact lens, we also had a study done at RB Center, RGP contact lens in these traumatic scars, they help quite a lot and they improve visual acuity. So I just wanted to add these points to the presentation. Otherwise, it was a wonderful presentation.
Thank you, Dr. Ajit Sinha, for your excellent deliberation and adding some important notes. I think this is very much important for the residents. And Do you want to share anything within the panelists or even from the speakers?
I will say to Professor Kadir, he has nicely mentioned, one of the student probably asked you that why you have told that nothing to be removed from the eyeball after the injury. Probably they wanted to know that you have mentioned that you will not touch, as you are not the cornea specialist, you should send it or refer it to ophthalmology. But what is your view on this question, Kadir?
Jay, thank you very much for a nice question. If we can, if in periphery, and that is in attending physician who is not the, there is no proper instrument or other things to manage this. So if we remove this foreign body, there is a open globe injury open, and intraocular contents become comes out through this wound. For that reason, we cannot try to remove this. And sometimes there is iris can just out, and this can be removed with the whole. That is from iatrogenic iris removal of the iris. For that reason, we not advised to remove this in these sub centers.
Okay. Sometimes we have seen in our practicing at the time that the ophthalmologist, there is no ophthalmologist, medical officer in the Upojela, they have got one injury of the eye, and they try to clean it, and then they are giving the pressure with the patches. Then it will create some problem that there will be iris prolapse, as well as the intraocular content may come out. So they should not give anything. They will just refer it. They should know how to refer and whom to refer. This should be their attitude. Fine.
So I have,
thank you, Noman. Next.
I have another question from the audience. What should be very much important after iris prolapse? The time or the color? If about the reposition of the iris, what is the consideration? The time or the color of the iris?
Both are important. Both are important. Time, if the time relapse, there is the epithelialization. So time as well as color. Color indicates that what is it is viable or not. If there is not viable, it will be excised, and if viable, it will be reposited.
So, what is your comment on this, Dr. Partha Vishwa, sir? Do you have any comment?
Thank you very much, and thank you for having me in this webinar. And it's a pleasure to be in Bangladesh day after day. Day before yesterday, and yesterday we were all ready to be here. And thanks for these wonderful webinars that you are having. My regards to Professor Ava Hussain ma'am and Professor Shafuddin, and every one of you who are here. Thank you so much. The iris is definitely a structure that if the viability is retained, then only it be retained. If the viability is not there, then it best be excised and taken off, and an iris repair be done. So as it would be a case-to-case basis, and especially if it is a long-standing wound with the iris prolapse, the epithelialization over the iris structure would have happened. And in such a case, this iris is not viable. There, abscission of the iris and then repair, and if whatever can be done to repair the iris internally should be done, suturing. And if at all the iris becomes such that it cannot be repaired, then of course we have the anterior rings, and they can definitely be a proposition in such cases.
Just one thing I would like to add here is that if the iris prolapse is too big and there is, it is of long duration, in that case, what we have done and is that you may not have to abscise the complete iris. If you dissect, then you may be able to dissect the superficial layer kind of thing from iris, and you will see a thin layer behind, and you can leave that. So if it's a large tissue, then you can do that, and it works quite well. And intracameral antibiotics in such cases is mandatory.
Thank you. Thank you.
Yes, thank you.
Thank you, Dr. Rajesh Sinha, for your comment. Now our next speaker, Dr.
Just one comment,
Partha.
Dr. Noman.
Yes.
Yes.
Next.
Next speaker. Yes, go on.
Yes, Dr. Parthopratim Datta Majumdar. I'm requesting Dr. Parthopratim Datta Majumdar to start his presentation. His topic is traumatic uveitis. Dr. Parthopratim Majumdar, the time is yours. You can start your presentation.
Thank you, Dr. Norman. First of all, thanks to OSWB OSB for giving me this opportunity, and my regards to Ava Hoshen ma'am and Sarfuddin sir. It's glad to see you all after a long time. So I'll be talking on traumatic uveitis. So ocular injury, as we know, that can lead to significant changes in one individual's life in terms of morbidity and the quality of life. So although eyes represent only 0.3% of a person's total body surface area, the loss of one eye leads to approximately 24% of the whole person impairment, whereas the loss of both eyes can lead to 85% of the disability. So having said this, I'll just discuss the 10 aspects of the traumatic uveitis today. The first tenet one should know is if you see a case of traumatic uveitis, you have to evaluate what type of trauma it is, whether it's a blunt trauma or whether it's due to some chemical injury or the spillage of some hot water. So you have to understand that what kind of trauma it is, whether this trauma has led to any iris incarceration or any other mechanical damage to the eye. So first important is to make sure that what kind of trauma you are dealing with. For that, you need to take an extensive history. The second point is it's very important to understand that what is the primary site of the inflammation, whether the inflammation is localized in the anterior chamber, whether the primary site of the inflammation is vitreous or it has affected the retina or choroid. So usually in ocular trauma, the vitreous is rarely inflamed, and the most commonly the inflammation is located to anterior chamber. So iridocyclitis can develop even after non-penetrating and trivial trauma also. And the reported cases of traumatic iridocyclitis range from 0.4% to 50%. In children, it's very important to rule out traumatic uveitis because many a time patient presents with anterior uveitis, and one has to differentiate it from the cases of juvenile idiopathic arthritis. So the third important point is rule out the other causes of anterior uveitis. Many a time, as we know by definition, traumatic uveitis is typically unilateral. So one has to evaluate and rule out the other causes of unilateral uveitis. This includes HLA-associated uveitis, viral anterior uveitis, and Fuchs uveitis. So HLA-B27 uveitis can be easily ruled out because it keeps alternating between the eyes. So if you take a detailed history, the patient will tell you about the recurrent attack or the previous attack. The viral anterior uveitis often it's thought to be manifested by the trauma. Any kind of trauma can precipitate the viral uveitis. So one need to carefully examine the cornea, whether there is any scarring, any other kind of capes you have to note. Fuchs uveitis is often seen and present as unilateral, and often we encounter the patients who will come to your OPD and will give a history of subtle traumas, trivial trauma, and on examination, a total cataract was found, and they will attribute it to the trauma. But whereas if you look carefully the iris details, you can easily make out that it's a kind of trauma. It's not due to trauma. It is due to Fuchs uveitis. Fourth point, very important, is always do gonioscopy and IOP measurement. It is very important because you can miss angle recession, and following a closed trauma, IOP measurement is very important. Particularly, I have seen many a time the children, in case of children, many people, they don't take the IOP and angle recession, glaucoma, and other things should be ruled out in such cases. Now, another important is you have to think twice before you level it as an inflammation in the vitreous in a traumatic uveitis. Though trauma is, you have to remember that the trauma is leading causes of vitreous hemorrhage in young people. And the small vitreous hemorrhage can often perceived as a multiple floaters, and often can be ignored. So one should avoid the diagnostic confusion between the vitreous hemorrhage and the vitreous inflammation. So for that, you need to examine the patient closely, and one should rule out the cells and hemorrhages. For example, if you pass a narrow beam, slit lamp beam, you can see here the inflammatory cells will appear relatively large in size. And as you can see in this diagram, the interparticle distance between them will be more. I'm sorry for the typo here. The interparticle distance will be more. Whereas in vitreous hemorrhage, if you see here, these will be brown to dark brown in color, and the interparticle distance them will be very less. They will be densely organized. So this is one way of differentiating between the inflammatory cells and the heme. So the sixth important point is always rule out traumatic endophthalmitis. As I said, that the vitreous inflammation is very less. So if you see cases with presence of intraocular foreign body, high history of penetrating injury in the affected eye, and vitreitis with or without clumps of debris, and the presence of hypopyon, you should rule out traumatic uveitis. The seventh point is explain all the patients about the signs and symptoms of sympathetic ophthalmitis. It is very important to explain the signs and symptoms because they may experience it, and you can prevent the loss of vision in other eye also. Because the early treatment of sympathetic ophthalmia has a very favorable outcome. So you have to explain the patient about the redness, watering, or any onset of ocular pain. And one important thing you can explain to your patient that difficulty to read and do near work is often the first symptoms of sympathetic ophthalmitis. Because of the inflammation of the ciliary body, often the near work difficulty is the earliest sign of sympathetic ophthalmia. So you can explain these signs to your patients with penetrating injury. So I'll just go a little bit about the sympathetic ophthalmia. So sympathetic ophthalmia, as you know, it's a bilateral diffuse granulomatous panuveitis which can occur any planned or unplanned injury with uveal tract or the iris incarceration. Now, I'll just show another case which was managed in Bangladesh, and ultimately we achieved a very good success rate, and it was very unique. So a 35-year-old female from Bangladesh who presented with painless and progressive loss of vision in right eye, and there was history of accidental burn with the hot water to the left side of her face involving the left eye 9 months back, as you can see here. So we have taken the necessary permission from the patient to show the photograph. So she lost her vision in the left eye and denied any history of other surgical intervention to the eye. So now you can imagine when it's such patient presents with inflammation in other eye, the good eye. So we usually level it as a inciting eye. The inciting eye is that eye which has suffered the trauma, and the sympathizing eye, which is the normal and which is reacting to the inflammation due to the antigen exposure in the inciting eye. So the patient presented with 660 vision in the right eye, and if you can see the fundus, you can clearly make out that there was a lot of SRA pocket, which is more evident in the ultrasound B scan, and there was also cells 2+ in the anterior chamber and plenty of cells in the anterior vitreous. So she was administered 3 doses of intravenous methylprednisolone followed by oral azathioprine 50 mg thrice a day. And on follow-up visit, you see her vision improved to 6.6 with resolution of the exudative retinal detachment. So when to suspect sympathetic ophthalmia, it should be considered in case of any uveitis which is occurring after any ocular insult. So it may not be a penetrating injury, it can be a scald, it can be any kind of chemical injury which has led to the uveal tract incarceration. So number 8 point is OCT can be a very useful tool, and it can help in identifying the early manifestation of the sympathetic ophthalmia in patients with suggestive history. So if you always perform OCT in a symptomatic patient with history or suggestive history and look for the serous retinal detachment, disruption of the iris-waist junction, and hyperreflective lesions at the RP, which can be due to Dellenfuchs nodule, and also look for the increased choroidal thickness. But you must remember that all these are very non-specific signs, and it can be seen in many other conditions. So proper evaluation of all these uveitic entity is very important. So number 9 is you should do, in presence of SRF in the posterior pole, you should do fundus fluorescent angiography, because many of the time these patients are very young and apprehensive. So before starting aggressive therapy in these young patients, thinking it as a sympathetic ophthalmia, I think you should do a FFA and see the fundus fluorescent angiogram properly. For example, if you see this patient was the other eye suffered a penetrating injury, and the patient presented with a subretinal fluid in the posterior pole. So my resident was suspecting sympathetic ophthalmia, and when we investigated with the fundus fluorescent angiography, you can see here the classical smokestack appearance. So it was a case of CSR, not sympathetic ophthalmia. So the last point is that treat aggressively. For our purpose, we have to remember that sympathetic ophthalmia is a condition that could result in bilateral vision loss or significant ocular morbidity if we don't treat them aggressively or rapidly. So always hit the inflammation hard. Use oral steroid should be used enough, soon enough, and long enough. Once you are sure about the diagnosis, don't delay the treatment. Use enough dose of oral steroid. Often we see treating a sympathetic ophthalmia with suboptimal dose of oral steroid like 20 mg or 30 mg, which creates complication, and it's very difficult to treat those patients later. And one should taper the steroid properly, weekly, not every 3-4 days, and follow them up very closely and monitor the clinical response and systemic symptoms. So here is the just flow chart to summarize the treatment of sympathetic ophthalmia. Like in normal cases, you should treat a case of sympathetic ophthalmia with topical steroid and cycloplegic for the anterior chamber reaction, and high dose of oral steroid to if there is any posterior segment involvement. If the patient presents with this three pattern like exudative RD, optic nerve involvement, or involvement of the macula, then one should go for the pulse corticosteroid or IV methylprednisolone. And similarly, if the patient is resistant to steroid, having recurrent attack of the inflammation in the same eye, then one should think of immunosuppressive agents. Just to conclude my 10 points on traumatic uveitis, the detailed history to elaborate the type and nature of the trauma is essential. Always try to classify the uveitis before you start treating them. Rule out the other causes of unilateral anterior uveitis before you start the treatment. Make sure it's the inflammation in the vitreous, not vitreous hemorrhage. Gonioscopy and IOP measurement is must in a case of traumatic uveitis, or rather in all cases of trauma. 6, beware of traumatic endophthalmitis. Don't mistake it as a pan-uveitis and treat them with oral steroid. Explain about the sympathetic ophthalmia to all cases of penetrating injury while discharging the patient. OCT can pick up very early changes, so don't forget to order one OCT in symptomatic patients with suggestive history. Always perform fundus fluorescent angiography to rule out the associated central serous retinopathy, and always treat a case of sympathetic ophthalmia very aggressively. Thank you.
Noman, unmute yourself. Thank you, Parthupratim, for your excellent deliberation. I think we'll go for the discussion. Noman, unmute yourself and then invite. Noman?
Yes, I'm here, no problem. Thank you, Professor Parthupratim Mojumdar, for your excellent and informative presentation. Now it's the time for the discussion. I'm requesting Dr. Amir to tell about something about the traumatic uveitis, and then I'm requesting Professor Deepak Nag to comment on this presentation.
Thank you very much, Dr. Nawan, for your kind invitation, and it's a privilege to be here. And a very nice talk by Dr. Majmudar. I think he has explained most of the points which we need to remember. I would just highlight a few things. One thing, as he mentioned about examination, is very important. I think especially in the children, it may not be easy to examine. Even the history-wise, children are not going to give you appropriate history. And sometimes what happens, the adults may not be accompanying there. So you have to be really good in examining the children. And other problem, endophthalmitis, we do get in children commonly if they have any injury, even if they are giving a history of non-penetrating injury. You may expect that they would have some penetration, but thing may not be lying within the eye, and they will have the endophthalmitis. You need to investigate, do B scan, carefully look the anterior chamber, look for hypopyon. It may be smaller. And I think coming to sympathetic ophthalmitis, I think it's very important that if there is no vision in the eye and injury is so severe that globe repair may not be properly done, it's important to discuss about early evisceration because risk of sympathetic ophthalmitis, we know that it starts within few days and keep on going up to many, many years. There are cases reported after like 30, 40 years. And other important thing I would like to mention that steroids, yes, initially, it's very important to use them, but most of these sympathetic ophthalmitis patients, they would require steroid sparing agents, and that you need to keep on using for a longer duration. You need to keep monitoring your patients properly, and that would really help.
Thank you, Dr. Amir Awan, for your tips and comments. Now I'm requesting Professor Deepak Nag. Do you have any comments on traumatic uveitis?
Yes, thank you very much, Patapati Majumdar. It's a nice presentation indeed. I have just 2 points. One is, I think once there is a trauma and vision does not correspond with the traumatic, the ocular conditions, OCT is also important to look. Sometimes, traumatic cystoid macular edema or macular edema can be there. Even there is no vitreous hemorrhage. So, so if there is a vision discrepancy between the traumatic uveitis and vision, then OCT can help you to identify there is macular edema or not, number 1. And number 2 is sympathetic ophthalmitis. Actually, when we were students, it was, we got lots of patients came with a sympathetic ophthalmitis. Nowadays, steroid, no oral steroid has reduced the number of sympathetic ophthalmitis significantly. So I think if there is trauma and if there is traumatic uveitis, we should start a systemic steroid, and that may reduce the incidence of sympathetic ophthalmitis in future. Thank you very much.
Thank you. Thank you. Professor Natarajan, do you want to say anything?
Unmute yourself, Natarajan. Yes.
Numan?
Yes.
Yes, sir.
Yes, sir. Shams.
Yes. Natarajan, yes, you continue.
No. What did you ask me to do, Shams?
Yes, I'm telling about the traumatic uveitis. Do you have any comments on this?
Sympathetic ophthalmia is a form of bilateral uveitis.
Right.
So when you do a primary wound repair, you have to make sure no intraocular content is incarcerated in the wound repair, so that you don't have that retinal S antigen released. So I think I hope our Partha will agree with that.
Yes.
I will ask one question to Natarajan and also Amit. What are the incidences of sympathetic ophthalmia in your country? As because in our country, I think the incidence is not much more. How you have calculated and how many patients you get there in sympathetic ophthalmitis due to traumatic uveitis? Partha can also say yes. Partha, have you got any statistics?
Yeah. The latest trend is we are observing sympathetic ophthalmia more with surgeries, especially the multiple vitreous surgery. Vitreoretinal surgery is one of the risk factor, and why we are encountering less sympathetic ophthalmia with ocular trauma is maybe the ocular trauma itself is coming down, because there's many country the safety gear they are using, safety glasses they are using. So the ocular trauma may be coming down. So that's why we are seeing less number of.
Yes. Amir Khan, Amir, Awan.
Yeah, thank you. I think in Pakistan, if I look at my practice, I think I'm seeing 1 or 2 patients every year. So still, I do see the patients, and I've got quite a few number of patients whom I'm managing with sympathetic ophthalmitis.
So what about in the Indonesia, Dr.
Yeah.
Gitalisa?
Gitalisa can
Thank
give
you.
some comment.
Thank you. So when I was still in my residency, I see more cases of sympathetic ophthalmia. Even by then, the numbers were not great. Maybe 1 or 2 cases during my residency. So I think we're quite lucky. And nowadays, I think it's even more rare. Yeah? So I don't. Maybe since the last 3 or 4 years, I only have seen 1 case. And well, I think that's because I think I agree with Prof. Deepak. Many trauma cases in my center in the university hospital are given whenever we cannot view the posterior segment, we give systemic or oral steroids. So I think that also helps reduce the inflammation and hopefully will help the fellow eye.
I have the observation with this that 3 things has reduced the sympathetic ophthalmia. One may be the less ocular trauma. Another one, use of steroid and protection of the eyes than previous. That may be the cause of less sympathetic ophthalmia.
Lot of
Less
interest.
ocular trauma, how, excuse me.
Yes, ma'am.
Less ocular trauma means, Shafuddin?
I was telling that previously the ocular trauma was much more. Nowadays, due to precaution, and the patients are also aware of, that's why due to protection as well as, you see, in our country, we are telling all the farmers, you will use the goggles during farming. So this is also one of the protections to the eyes. In this way, I think the injury is less. That's why sympathetic ophthalmia is less.
Penetrating injury is not that much less. There are so many penetrating injury are coming now. That's because in National Institute, in Dhaka Medical College, there are always penetrating injury is coming. But agricultural injury, I agree with you fully that due to awareness development and they are using goggles during harvesting season. So that thing are listening now.
And I was telling madam that there was also
I have a question
awareness.
to Partha Pratim, please.
Yes, ma'am.
I have a question
Yes.
to Partha Pratim. You have said very nicely one thing that every patient of penetrating corneal injury, you are explaining the sympathetic ophthalmia, sympathetic ophthalmitis to the patient. What you want to say to the patient? What they will look for or what they will do?
No,
What explanation you want?
Yeah, just explain the patient that if you develop redness, watering, ocular pain in the other eye, you have to come for ocular consultation.
Awareness, yes.
I think
Very
Rajesh.
important thing. Yes.
I think Rajesh Sinha sir
one
wants
thing
to.
yes, Rajesh
Yeah,
Sinha?
I just wanted to add one thing. I think Ava ma'am also told that, even now because of so many other factors, we also get, because since maybe we have this is our center is a referral center. So we get a lot of cases of traumatic injuries and all that. One thing I feel that probably we have better quality microscopes available these days.
Correct.
And the repair is better, and the uveal incarceration is less after the repair. That is perhaps one
that
reason.
is the
People
main
who are
thing,
working
yes.
on loops, they are having some microscopes which are obviously less costly, but still they can afford microscopes. Those who had lesser quality microscopes, they are having better quality microscopes. I guess that has improved things quite a lot.
Yes.
Thank you. Thank you, Dr. Rajesh Sinha.
That is quality of management is improved. That is the main thing.
Yeah, I'm requesting Dr. Tariq Reza Ali for his quick comments. Lot of interest over these topics, and lot of residencies are asking questions. So quick comments from
And
Dr.
after
Tariq Reza
Tariq
Ali.
Reza, Partho Pratim will also say something. Partho Biswas will also say something.
Yes.
Dr. Partho Pratim
Tariq.
actually he has created a very beautiful history here.
Can you speak loudly, sir?
Yeah, Dr. Partho, I want to add one thing, that during examination, actually we have to think of indirect ophthalmoscopy bilateral indirect ophthalmoscopy, you can't ignore that. That is very much important. Say if you find that usually by blunt you will find anterior uveitis or iridocyclitis, but you have to search in the vitreous, in the retina also, what are the trauma is there. One thing I want to add. Another thing for Dr. Amir was telling that for the children, actually we have to go for examination under anesthesia. That is very much important to rule out any other trauma, any other thing. And lastly, actually, I want to ask Dr. Partha Pratim Dr. Majumdar, what is the pathogenesis? What is the pathogenesis of traumatic uveitis? Can you tell us?
Yeah. So pathogenesis of, if you ask me the pathogenesis of sympathetic ophthalmia, then it is the typical example.
I'm asking actually traumatic anterior uveitis. Why does it occur?
So there is no clear-cut cause for that, but most probable there's some mechanical injury which causes the breach in the barrier, blood aqueous barrier, and the iris starts leaking the protein and exudates into the anterior chamber. So that is the most possible explanation for that.
Yeah, the after effects of the concussion.
Yeah.
Priya.
Yeah, no, I just said that they are just the after effects of the concussion of the injury, because these are usually blunt traumas which give rise to such kind of things. So it's always a repercussion which is coming up. Maybe you don't know whether the angle is involved or which structure is actually involved. Many times we happen to see, we don't see anything in the immediate period. We might see it maybe after a few days or maybe after a few weeks. So it's always the manifestation which comes up, not exactly an exact cause. It depends on which structure is damaged at that point of time.
Dr. Partha Vishwas, will you want to say something?
Yes, sir. Yes, sir. Thank you very much. So just wanted to say the same thing. The incidence of sympathetic ophthalmia has definitely gone down over what was taught in our textbooks when we were residents. And now the figures are somewhere near 0.03 per a lakh of patients which have been examined. This is from a study that in Northern India. And however, that there is also evidence that in children, the sympathetic ophthalmia numbers are more as compared to the adults. So that is a very important fact. And I think this should be borne in mind when examining a child, and a follow-up examination, aggressive treatment, and a long follow-up examination regularly should be done for especially children, and obviously for adults also, but with special notice to this aspect.
Thank you.
Thank you, Professor Partha Vishwas, for your comments. Now we are coming to our third speaker. I'm requesting Dr. Priya Naran to start her presentation on traumatic iris repair. Dr. Priya Naran, you can start your presentation. Time is yours.
Yeah. Is this seen?
Yes, it's visible.
Okay. So at the outset, I would like to begin my talk by thanking Dr. Shyam Saman for giving me this wonderful opportunity, and also to Professor Rava and Professor Shafruddin. I'm really very glad to be here in front of such a beautiful group of doctors and panelists and the audience. So thank you so much for having me here. So, well, I have been asked to cover up the traumatic iris repair. So I would just go ahead with the various things that actually, whenever you have an iris damage, so the points that come forward in your mind are that you need to reconstruct the pupil. First is aligning the pupil center, and then you need to have an iris base reconstruction. You also need multiple surgical approaches and techniques, which you might need to have a perfect kind of pupil that you really want. And then comes the artificial iris, where probably when you can not do anything and maybe the entire iris is damaged. So there are various aspects of treatment of iris repair in the case. So I'll just go ahead. I'll first show, this is what I'm going to show it today is just the surgical method of how to go ahead with the things. And I'll be just trying to show a few methods of reconstructing the center of the pupil and also the base of the iris tissue. And I think maybe the audience and the uh, residents, they can understand this and for the benefit of their patients. So the first thing I'm just trying to show you is a single pass pupilloplasty procedure. This is the animation. You can see here, we need to reconstruct a part of the iris tissue and also the pupil. So what is being done here is that you have this a 10 or a 9 needle, which comes up from this side, and then you introduce through the paracentesis the needle, 26 gauge needle, which railroads the method, and then you just pull this loop of suture, and the suture end is passed to this 4 times in the similar direction, and that is why this technique derives its name, the 4th row, and then you just cut it off. You don't have to take another pass with this, and this is actually very helpful in cases of traumatic cases, because already you are having an iris pigment dispersion in the eye and everything. So with one single pass, at least one area can be done, as compared to other methods where you at least need 2 or 3 passes to be done. So I think this is just an animation which I just tried to describe you. This is the technique which was described by me in the European Journal about 3 to 4 years back. So this is first clinical case. The severity of the iris will keep on increasing as the video keeps on coming. So this is just a small iris defect that you are seeing initially, and you just need to reconstruct this. So when you have a localized sectoral involvement of the iris tissue, then it's just a simple pupilloplasty procedure, which helps you to reconstruct this. So what you actually do into this is you need to have paracentesis incisions that you had it here, and you had this 9 suture straight needle passing through the proximal iris. And then from another paracentesis, you introduce another needle and you railroad this and you pull this out. And then from the with the help of this loop or whatever you have the device in your center, you can pull off this loop from one of the paracentesis, and the suture end, which was lying on that side, you just need to take 4 throws. They are being taken in the same direction. They cannot go in the opposite direction. You have to take in any one direction. In that direction, you have to go through that 4 times and you just pull it. This creates a self-locking mechanism. It has a self-locking. So you do not have to take a second pass for the same thing. You just have to take an intraocular scissors and you just cut this off and you are done. So actually this repair procedure keeps on going on till you are comfortable and you have finished off doing the entire area. Now you have this much space which is left out. So you need to do this procedure again. It's a very simple procedure. I think everybody can go ahead and do it in their clinical practice and try to achieve the kind of pupil that you actually require and you want it for your specific case. You can do it with viscoelastic, you can do it with fluid infusion. The choice is yours. It also depends upon the case, what kind of case you are having. And based on that, you need to have a good tonicity in the eye, which you can have with whatever you desire. And you just close up this. So this was just for the center of the pupil. I go up with one more severe thing. Now, this is a case which had come to me. This was a corneal tear repair was done by the referring surgeon. So now what you see here is the corneal opacity. The sutures have been removed. The patient had cataract. I was asked to talk about iris repair. So I have edited my secondary IOL fixation. This patient had a subluxated lens, which was also present, and I have done a secondary IOL fixation with the glued IOL procedure. You can also see the flaps on both the sides. So I have done with this. Now what you see is that I also need to reconstruct the pupil here, but my visibility is very poor in this case. So what I actually try to do is, because I need to construct the pupil in the superior and in the nasal area, but visibility is almost 0. So what I try to do, I try to do these things in a different way in this case, because, you know, at times I try to use the oblique illumination, etc., to help me see from this area, because I know I need to pass my suture from somewhere here and it should come out, but I'm not actually sure of how much amount of iris tissue is there. Now, what has happened is that I have just created the paracentesis. So something just strikes me, and what I try to do is that, you know, I try to pull the iris tissue from here to here. I try to reconstruct the pupil. I know this is going to block the entire center of the pupil, but I'm trying to do this because I know that when I do this, whatever amount of iris tissue which is probably lying behind this scar will also be pulled along with it, and it will come into the center, and then I can undo the thing which I have which I'm doing right now. So I'm trying to do a single pass photoreceptoplasty procedure again in this area. And you can see the similar procedure I have repeated. I have taken up the hook and the suture loop has been withdrawn, and I'm just going to take up the 4 throws and do the pupilloplasty procedure here. This is just the 4 throws which are being taken. I have just fast forwarded this video so that you know I can show you the entire thing. So now having done this, once I pull this, I know this entire iris tissue has come up. Now I'm doing this procedure only with the help of my tactile sensations, because I'm not seeing anything beneath this scar, but I'm damn sure with my tactile sensation that with this end opening forceps, I have hold the iris tissue beneath it. So I have passed it from the proximal iris tissue. I'm coming up from the distal iris tissue. And you can see in these traumatic cases, the iris tissue often, you know, they are very fragile. Even a 9-0 needle is creating such a big hole in this iris tissue. You can just have a look at this. It's just a small needle which has passed through it, and there's a big hole out there. That means the iris tissue is probably very fragile and it has gone through a lot of trauma. So now what I'm trying to do here is that I'm trying to do the similar procedure of single pass 4 throw in this, and I know my iris tissue, I can see a bit from here which is being pulled off, and I do the similar procedure and then try to reconstruct the pupil. Now you will say that, madam, you have just closed up the pupillary area also. What extra thing are you going to do? I think maybe I might just fast forward this a bit. So I'm just cutting off the suture ends here. And what then I do differently is I take up the vitrectomy probe, because now I need to cut off this iris tissue which was present out here. Anyway, so with the vitrectomy probe, I try to fashion up the pupil so that there is an area from where the source of light is there for this eye. And definitely this patient is going to undergo a penetrating keratoplasty in future. But at this moment, when I have done a secondary eye fixation, I have reconstructed the pupil. Now what is going to happen is that at a later stage, when the penetrating keratoplasty will be done, for this case, at least there is an iris tissue barrier which holds on, and there is a full compartmentalization of the eye as an anterior chamber and as a posterior chamber. And that probably increases the chances of graft survival in the next surgery, which will be done for the cornea. But anyway, this patient was very happy. The patient had a 660 vision, not much. 660 was quite good, because when the patient came, hardly had any counting finger kind of thing in this case. So anyway, this is one of the things that I just wanted to show, that many a times, you know, in these cases, we do face some challenging things. Okay, I'll just try to show, this is again a traumatic iridodialysis. And you can see that the patient also has a cataract. The patient also has an iridodialysis out here. So this is one of the techniques which I'm just going to show you how to reconstruct the peripheral iridodialysis. This is actually by Dr. Mami Kusaka and all. They had presented in the ACRS last year, and this video, this method had won. So I just picked up this idea from there. These are the Japanese doctors. So what initially what I'm trying to do in this case is, you're just doing a cataract extraction, removing the nucleus and phacoemulsification, putting up an intraocular lens and all that things, which is commonly done by everybody. Secondly, what this iridodialysis is not very big. It can be easily managed. So what I'm trying to do in this with this method is that this is a 6-0 polypropylene suture, which is cut down into pieces of about 6 to 7 centimeters. And we take up this hot cautery, and we're trying to create a flange. This something like a Yamane method, where we try to do it for the intraocular lens. So a flange is being created, and then you just press it with the needle holder, and that increases the diameter of the flange. Now this flange is going to hold the periphery of the iris tissue in this method. So what we actually do is that around the area of the iridodialysis, we try to make a scleral groove. And from the scleral groove, this is a 30 gauge needle which is going on. It goes on into the iridodialysis, the base of the iris, from where you want to pull this off into the periphery. And the suture, which was flanged, is then passed through this. So it is just threaded into the barrel of this needle. You can just see it is being put inside, and then you just pull the needle. So what happens along with this is that it will just pull the 6-0 proline suture along with it, and this flange, which was created initially, is going to hold it over. So that is why this technique is known as a double flange technique, because you're going to create flanges on both the sides. This is another piece of 6-0 proline, and again, a low temperature cautery is taken, and again a flange is created. So it all depends upon how much area of iridodialysis you have that you might be needing to do these passes. So in this, I think twice, if you do it twice, it suffices the need. So again, this 6-0 proline will be again threaded into the barrel of this, and it will be pulling up. So this is one flange which is created on one side. Now what actually happens is that you also have a sutures coming out from this side. So you're going to create with a low temp cautery, you are going to create another flange here. So there will be two flanges which will be holding the iris tissue into the periphery, and that is how this technique derives its name. So you will cut down the extra suture which is lying here. This goes off, and then again you try to create a flange till this flange goes, till it achieves its proper size, and then you just push it back into the scleral groove, and then you can just close off this conjunctiva either with a cautery or with a fibrin glue, whatever is available in your practice. So now practically there are two flanges on both the sides that hold this peripheral iris tissue into its place, and it really holds on very well. So this is one of the methods, like if you have some traumatic iridodialysis kind coming up, you can do it in your thing. Otherwise, we have various other techniques also, which we try to do in these cases. Dr. Shams, please do let me know if I'm running out of time. So this is another method. This is a two-port technique for iridodialysis repair. This technique was again described in the Journal of the Cataract and Refractive Surgery. And this is actually a combination. Sorry, I just skipped the video. This is just a combination of the non-appositional repair along with a single pass orthopubloplasty procedure, because now comes in the combination of the procedures. If you have a lot of iridodialysis, this is a traumatic iridodialysis, you have a lot of iridodialysis there. So you need to reposit this entire periphery of the iris tissue into the base. So you will be needing multiple approaches, because not one single approach is going to suffice for this patient. So once this is actually a case with a secondary oil fixation, which needs to be done for this case. Initially, what you try to do is that this is a big iridodialysis. So you first need to fix it off. If you do not fix it off, you have to use an iris hook and you have to clear up the central area. And then you have a central area, you can do a secondary oil fixation, release the iris hooks, and you can again do this procedure. But you can do it in the beginning also. So you just take a double arm suture, which is actually needed for these cases. And through the periphery to the base of the iris tissue, you just pass this, and then you railroad this and you bring it out through the scleral tunnel, and then you just pull both the suture ends and the entire thing comes off along with it. So this was basically described by Dr. Snyder from Cincinnati, and this we call it as a hangback technique, or you also call it as a non-appositional technique. So you keep on doing this till you have the entire area of iridodialysis that needs to be repaired, and then you can just go ahead and do a secondary oil fixation method, and that is how you come across this. So I think I'll cut short this video for the secondary oil fixation. I'll just try to show you one thing. One thing for newcomers who are venturing into the iris repair procedures, I would just like to tell you that, you know, it's very essential that when you pass the initial suture, you should not imbibe the corneal tissue into the needle. If you imbibe the corneal tissue into the needle, your surgery will fail, because when you will try to pull the suture, the loop is not going to slide inside the eye, and it will remain as it is, and it will add to your frustration because the iris tissue is already so fragile and you're not in a position to do the procedure. So I'll just try to show you one of the newer methods we have recently described in the European Journal, is the trocar-assisted non-appositional iris repair. So what actually happens in these cases is, I'll just put this off here. You just take a 25 gauge trocar, place it into the anterior chamber, and then you take a double arm suture and you pass it through this. So this barrel of the needle actually, it prevents the imbibement of the peripheral corneal tissue. If you feel that, why do I need to use a trocar to do all those things? What you can do, and what I also often do, is, you know, you can even take a spatula, an iris spatula, you can place it and you can slide the needle over it so that it does not imbibe any corneal tissue, and it touches the spatula and it goes inside. So this is one of the clinical points which is very important to doing this. So we just happen to describe this as a trocar non-assisted, trocar-assisted non-appositional repair, wherein procedure is the same, but it is just that it helps you to prevent the imbibement of the corneal tissue inside this. So these are some of the things which I just wanted to show you, that maybe if anybody is interested in going into the repair, they can use some of these surgical techniques and procedures, and they can optimize their visual outcome in their cases. I think I should close it down. And if anybody has any questions in the audience, you can just email me. My email ID is below, because I cannot cover everything out here, but I can definitely reply to your mails. Thank you so much.
Thank you, Dr. Priya Naren, for your excellent presentation and excellent videos. You did really a word. It's really a word, actual word. Congratulations. And for everybody, she has already awarded for these videos, and she's really a specialist in the people repair, iris repair, and we are really delighted to have you with us. Do you have any comments from any? It's an open. Please.
I just have a question,
Yes.
Dr. Priya. I mean, we understand that once the iris is injured, there could be lentil opacity, and you will remove the cataract and you will place the intraocular lens. But the thing is, if you find the lens is clear, do you go for will go for for iris repair?
Well, this is a very tricky question, but it's a very genuine thing that if there is only a iris tissue defect, first thing, and if the lens is clear, that's what I think your question is. Indirectly, the question is that would you do an iris repair procedure in a normal lens? That's it. Actually, you have to be very careful when you're doing an iris repair. Let me tell you, any intervention into the anterior chamber with a clear lens can lead to cataract formation. So that is first thing. Secondly, you have to assess how much amount of iris tissue damage is there. Suppose if it is a very minimal kind of thing, which does not cause any visual disturbance to the patient, you can leave it as it is. And you can explain to the patient that, look, this is the condition, and you might do well without any intervention. But if there is a very big iris defect or something, and if the patient is symptomatic, patient has visual disturbances or glare or photophobia or whatever because of the iris tissue, you need to take the patient into confidence and you need to explain. Now, at this point, you have to take many things into consideration. What is the age of the patient? Suppose if the patient is young patient, probably then things are again tricky. Because a young patient with a normal lens and taking away the accommodation of that patient, actually it's not pardonable. So you need to explain to the patient. If the patient is ready, you might even end up saying the patient that this procedure might cause you cataract. First thing is that no matter how good your hands are, no matter how good your surgical hand is, you might touch the anterior lens capsule and it might lead into it. If the patient is ready, you have to say that we need to do this procedure with lens extraction, if that is the case. So I think it's a very tricky thing, but yes, you have to be very clear in what you are doing and you need to explain to the patient. So I think it all depends from the surgical scenario, the clinical condition which is present at that moment.
Can I have two questions for you, Dr. Priya?
Yeah, sure.
Yes. One is what needle you are using the Prolene suture for this single pass 4-through pupilloplasty. But yes. What Prolene suture? It is 10
It's a polypropylene. You can use a 10 or a 9-0, but I prefer to use a 9-0. A 9-0 polypropylene suture I'm using, a double arm for an iridodialysis and a single arm for single pass 4-through.
And what is your experience about the post-iridodialysis repair uveitis? Do you feel that after this repair, the uveitis will be aggravated after this repair?
No, not exactly, because if it is associated with a secondary oral fixation, you might see some kind of inflammation, because it all depends how much amount of damage has been there, how much manipulation has going on, how many surgical interventions you have done, because you are handling the vitreous also. When you are doing a secondary oral fixation, you have a vitreous element. So, I mean, yes, you might have an inflammation in the post-op period. I don't deny it. Yes, it is possible you have an inflammation, and you have to take care of the inflammation also, because at the end of the day, you are handling a uveal tissue and which gives inflammation. So let us accept that.
Okay. Do you have any comments from the panelist?
Yeah, can I ask one thing, Dr. Shams, to Dr.
Yes.
Narek?
Yeah.
Yes,
Amit.
Very nice talk. Have you tried any other suture like Gore-Tex suture or any other suture apart from Prolene?
Gore-Tex sutures we are not using for iris. Gore-Tex sutures we use for back fixations.
Yes.
So for iris, I think we
Just
are all
Prolene,
using.
yeah?
Yes.
Prolene, yeah. Nothing else. Okay.
Nothing.
Thank you.
So thank you so much.
The war was so hard, but very smoothly and very politely with the soft hand, Priya has managed. Very good.
Yes.
Thank you.
Thank you.
Thank you, sir.
So I'm requesting now Professor Partho Vishwas to start his presentation on traumatic cataract management. Professor Partho Vishwas, now the time is yours. You can start your presentation.
Thank you very much, Dr. Mann. And is the screen visible?
Yes. Slide is visible, but
But
still no presentation there. Yes, it's
okay,
visible now.
right. So it's definitely been a war, and a war has been won for every one of our presenters who have really elucidated the wonderful nuances of each of the topics. I'm so sorry to have been late and have missed the first few presentations, but the later ones by Dr. Priya and by Dr. Parthapratim were excellent. Thank you so much. So the traumatic cataract, and this is so the traumatic cataract, and in this we come to the different situations where such cataracts can occur. And we do remember that these cataracts are associated with other comorbidities of the eye itself. And I'm going to present a few cases, and I would like to have your opinion, and we'd like to learn from each other what could have been done and where I faulted, where I flawed. So this is a case of a traumatic cataract. And this patient, a young patient, but he had waited nearly 15 years after the cataract. And this is what the cataract was when he first presented to me. So this cataract, a rock hard brown cataract, and it was nearly half popping into the anterior chamber when we first examined. So we planned out the cataract, and this is what we had to do for this patient. We had to give viscoelastic, and this viscoelastic is important in this case, but it also comes with a difficulty. The difficulty is that once the viscoelastic, and this was a high molecular weight viscoelastic that we used, and here when we do have an anterior chamber through which we can work, but how do we get the trypan blue to stain such a hard cataract where no view is visible? So here the technique is to smear the trypan blue and to go ahead with the smearing and to smear as much as possible so that we do have a good stain. Without a good stain, the anterior capsular excess can be a very, very difficult proposition and can run out. Even at points where the capsular excess is not visible and the stain has not taken up properly, again, a little bit of maybe rewash and restaining is something that should be done so that you have at the end a good capsular excess, because that is the essence of a good traumatic cataract surgery. So here we come to this phase where we have been able to perform good capsular excess, and we put in the capsular hooks. And once the hooks are in place, the lens is nice and stable. So here we have over 180 degrees of subluxation. And with this 180 degrees of subluxation, we do know that there are many maneuvers, many devices that have to go in. But the first of these devices is the CTR. And this has to go in very well, and so that the lens capsular bag becomes well centered. So once it is well centered, a very, very gradual hydrodissection, and we are able to rotate this nut of a nucleus in the capsular bag. So once it rotates, now the disassembly of the nucleus and the whole capsule is, as usual, filled up with this hard nut. So direct chop is one technique that has to be attempted, because with such a hard cataract, if sculpting is done, it dissipates so much more energy. And remembering the fact that the maneuvers should be very, very gentle, and you can see that the capsular bag is being held so well with the capsular hooks. And I've got a capsular a break in the nucleus and to the periphery. And the first pie is the most important pie of this whole maneuver. So if the first pie is done, then we are able to go ahead and continue with the other pies of the nucleus. So gradually the nucleus comes out, And it is a lot of patience, it is a lot of gentleness that all these nuclear fragments need to come out. So viscoelastic, viscoelastic, and viscoelastic cover is the mantra. And with a good viscoelastic cover, gradually the nucleus can be disassembled. And then the intraocular lens, we had chosen a single piece intraocular lens, but in all traumatic cases, a multi-piece lens that can go into the sulcus as and when required always should be there in the OR, along with all the devices that we have. So here we have to fixate this capsular bag, and once the lens is in place, so here is what we did. Now, I would like to tell you here that this is, at this point of time, what we had was a little bit of a mishap. And the Ahmed segment that I was supposed to use had fallen on the floor. And what sister gave me instead was a broken Sioni ring. So this Sioni ring is the only device that I had with me in the operation theater, and I fixated that device. One thing that I had to do at this point of time is knowing very well that this device had a broken edge, which was an edge that was a ragged edge. So that ragged edge I cauterized, and then I placed it in the bag so that the ragged edge would not puncture the capsule at any point of time. So having done that, we closed the wound, and the patient had a well-centered IOL with a fixated bag. Let us look into the next case. And this is again a case in which we have a subluxated lens. We need to use devices, and of course, now here again, it is a nearly 180 degrees subluxated lens. And the first step that we do is to try and seal that opening to the vitreous by high molecular weight viscoelastic. The second thing, and the most important thing, I try and center the rhexis on the subluxated lens. That means we have to be a little eccentric to the cornea. So we have placed in the 5 millimeter marker of the capsule, and with the initiated with the capsular tome, but at the end, the capsular rhexis has to be completed with the microforceps. And the microforceps and the micro scissors are very, very important tools in this. And the edge of the microforceps has to be very nice and accurate, has to be atraumatic, and has to be well accentuated. So the next thing that we do, and this is going a little outside the principle of a traumatic cataract, and I've created the main port from the area where the subluxation is most, and then I'm putting in the CTR. Why did I do it? It was a very deep-seated eye, and I could not get good access from the superior side. So I went ahead and entered the main port from the temporal side. And then here we are holding on to the capsule by the iris hooks, which are also devices that can be used in such situations. And I'm specifically showing this video so that our younger surgeons, if they do not have capsular hooks, which are more atraumatic, can use the iris hooks instead as well. The next important part of a traumatic cataract disassembly is the rotation of the nucleus. And if it does not rotate well, which means that there is an obstruction, the hydrodissection has not taken place, and the hydrodissection per se in itself is a maneuver that has to be gentle with small, small squirts and has to be done well. Otherwise, it will not. The next part, of course, is I'm taking out the iris hooks out of it, and the CTR, you can see a part of the CTR, which means it's a well subluxated bag. So here again, we need to use the devices. And first we place in the intraocular lens, and then I would go ahead with the device to center the capsular bag. So once the intraocular lens is nicely in place, we need to see whether there is any amount of vitreous. And there is vitreous in the anterior chamber. And so we do a vitrectomy of the anterior chamber. And as soon as the vitreous has been removed from the anterior chamber, the next part is, of course, the lens becomes a lot more stable. Here, I should have resorted to a Hoffman's pocket, and that would have been a much more elegant technique if I had created this Hoffman's pocket initially before opening up the eye or making any of the ports. But this, of course, is not a very elegant way of doing a scleral pocket. And you can see it's a little ragged. And then we place in the amide segment well inside. And once the amide segment is placed, and here again, we need to reiterate that one segment would do well enough for these eyes where it is not a case of progressive zonulopathy. A traumatic cataract with zonular dehiscence will not dehisce the rest of the zonules most of the time, unless there are any other factors to it. And therefore, we can rely on the rest of the zonules to hold the bag. So here in this case, one amide segment would be good enough for this. So we place in the amide segment, and it can very well center this bag. And all the time that we do these maneuvers of the railroad technique, if there is loss of the viscoelastic has to be replenished time and again, because if this is not done, then naturally there will be a shift of the anterior part of the IOL bag complex, and then we will have trouble. So repairing the tissues is important, and of course seeing whether any amount of iris repair needs to be done, any of the other structures need to be seen. And at last, of course, it is important to put in tricot and see whether the vitrectomy has been complete in these eyes, because the vitreous, what you cannot see through the microscope, becomes extremely well delineated when you put in triamcinolone. And then, of course, putting in the suture. I have opened the speculum a little, and before I finally close the conjunctiva and see that there is a well-formed AC, the loosening of the speculum is definitely a must. I come to my last video, and this is a video with a lot of memories. And this patient we called Bhuvan. And he's a gentleman who first came to us with a huge amount of repair, and there was vitreous hemorrhage. We thought there was a foreign body also in the eye, and there was a slash of the cornea. We did a primary repair, and as you can see, there's traumatic aniridia as well. And with this aniridia, we waited for 4 months, and after 4 months, we took this patient up for the cataract surgery. So we have here an aniridia that is there, a primary wound that has been repaired, and what we need to do is to remove the cataract. There is not much of iris tissue, and we cannot salvage it, and we need to take care of that part as well. So a very gentle hydrodissection and hydrodelamination. And in all these cases, as you can see, that the handling of the nucleus is very, very important. And at any point of time that you think that the bag cannot be well centered, or you're having difficulty with the bag fixation, the devices must come in. And the devices are of great importance for all these traumatic cataracts. And straight chop is a very, very good way. However, the other methods also work. However, the dissipation of energy is always there, but whatever you are comfortable with will do the job. And in this case, where we had actually thought there would be possibly a foreign body, actually had disappeared, and there was no foreign body. It was just an artifact. And here you can see that I'm putting in the intraocular lens right in place, and there is still a fragment there. Why? Because I thought that I had ruptured the posterior capsule, or there was a dialysis, but thankfully there was no dialysis, no rupture of the posterior capsule, and we removed that the part of the nucleus after placing in the intraocular lens. So then comes in the reconstruction of the iris, and the iris gets reconstructed by these two reconstruction rings. And I specifically want to tell you that these reconstruction rings are quite bulky, and all of it goes into the bag. So the bag has to be a stable bag, and you can imagine there are 4 devices that have gone into this bag, this traumatic bag. So just think of the strength of the zonules, the God-given strength of the zonules that is there. So the intraocular lens is there, the CTR is there, and these 2 bulky reconstruction devices have also gone in. And they are getting manipulated, they are getting shifted. And, at the end of everything, it is a well-centered bag and a well-constructed iris. So we call this patient Bhuvan, and we made a short film of Bhuvan, and Bhuvan achieved a vision of 6, 9, and 6. Thank you very much for your patient hearing.
Thank you, Professor Partha Vishwas, for your excellent presentation and excellent video documentation.
Thank you.
And we really enjoyed. And do you have any questions, the honorable panelist? We are running short of time, actually. If you have comments, Dr. Rajesh Sinha?
Yeah, actually, the surgeries were very good and mind-blowing. Dr. Partha, I must congratulate you for that. Only the last case, will you prefer an aneritic lens instead of putting 3-4 things?
Yeah, Rajesh, you're quite correct there. An aniridia lens would also be a very good option. In fact, at that point of time, the aniridia lens was not available with us. So we could procure these reconstruction rings, and we went ahead. Another small point that I would like to tell you here. These reconstruction rings are indigenously made, and today, it's this patient is 8 years from the day of surgery. He still comes back every 6 months to have his eye checked, and there's no chaffing, or there's no the pigments of the reconstruction devices are still very much intact, and there is no glaucoma. And of course, we were very lucky with such an amount of trauma. There was no post-operative rise of intraocular pressure, and has been maintaining such.
What was the vision of this patient?
Yes,
Vision is
6'9".
Yes,
6'9".
Mind-boggling. This is mind-boggling.
Very good.
We call him Bhuvan. Bhuvan after Lagan ka Bhuvan.
Yes.
Very good. Excellent.
So, what about the toxic lens syndrome? If it is a traumatic cataract, the lens-induced uveitis, and when you are doing the cataract, what should be the time limit? I think Dr. Parthopati Majumdar and Partha Vishwas, both you can comment on this. This is a common question for the residents.
Yes. So the time limit. So when the patient first presented to us, there, as you could see, there was nearly about 160 degrees of rupture of the cornea, and it was a concentric rupture on one side. So our first and most of the iris was popping out, and we thought that possibly vitreous was also coming out. But very luckily, when we did the first repair itself, the anterior segment settled quite well. There was vitreous hemorrhage as we showed, and there were artifacts which we thought there was intraocular foreign body, but it was not there. The cataractus change was not there at that point of time, or minimal. It was minimal. So our first intention during the first primary repair was to restore the integrity of the globe. Do nothing much, do just to restore the integrity of the globe, and which we did. And it really paid off extremely well, because in 4 months, the anterior segment settled, it became quiet. The posterior segment, the vitreous hemorrhage, disappeared, and we could see the fundus. And what we did see, that the fundus was quite good, and there was no intraocular foreign body, even on the ultrasound or otherwise. And then when the patient started losing vision because of the cataractus change that was coming on, then we thought of doing the cataract surgery. So we did not hasten into the cataract surgery, I think, which was a saving grace. And even the macular status was very good. The OCT, etc., what we had done was extremely good. And so we thought that, yes, we could restore good vision for this patient.
Thank you, Professor Partha Vishwas. I think Professor Parthopati Majumdar is there. Dr. Parthopati Majumdar?
No.
Hello?
Okay, you can request
Okay.
our next speaker.
Okay. So I'm requesting Professor Dr. S. Natarajan to start his presentation about the traumatic retinal detachment. And I'm Professor Natarajan, sir. Are you there? Hello?
We cannot hear him.
Hello? Hello, Dr. Natarajan?
I'll just call him.
Yeah.
Yes.
Yes.
Yes. Natarajan is here.
Yes.
Okay.
I just came
In a relaxed mood.
Oh, with Achi.
Yes.
Namaste,
Bye.
Achi.
Yes.
Okay.
Yes. So should I do my presentation?
Yes. You start.
Right. I'll just share my screen.
Yes.
Yes. So
now you can share your screen.
So this is a case of a road traffic accident who came with a closed funnel retinal detachment and suprachoroidal hemorrhage. So this was a 34-year-old male presented with a closed funnel detachment with suprachoroidal hemorrhage following the road traffic accident. So I took her up after the corneal wound repair was done, and then the surgeons actually said that nothing more can be done. So then they referred to me. So you can see the temporal retina is incarcerated to the nasal retina, and it's like a total like a flower, totally closed. Then I used the chandelier illumination, used two 4-port vitrectomy. The 2 ports I used 2 forceps, separated the folds, injected the perfluorocarbon liquid opened the funnel. You can see the retina is attached now. I'm gently stroking with the retinal brush and flattening the retina under the PFCL. I'm also doing the endolaser photocoagulation, the 360 degree, because already 300 degree giant retinal tear was there. The rest of the 50 degree, I actually increase the relaxing retinectomy. And you can see some choroidal detachment residual present, but I didn't think that the retina will open, but you can see the corneal sutures and which was there, and through the corneal sutures I used. So this is the preoperative view with the total detachment, and then still the central corneal suture is there, and the retina was attached. So this was a case where I wanted to say that usually people want to give up. So I don't give up. So I have any complicated retinal detachment, I make sure that I do my best, but I spend a lot of time before I start the surgery with the patient.
So we lost your screen.
No, I'm just
sharing.
I'm sharing.
Yes.
So this is another traumatic retinal detachment with an inferior PVR, where you need a relaxing retinectomy. So the historical review, the first description of relaxing retinectomy doing pars-plana vitrectomy was done by the father of vitreous surgery, Robert McMurray, and then later Dr. Elder Jovanovich, who's the father of modern retinal detachment surgery, particularly with silicone oil, and who has done the maximum number of retinal surgery at that time. He retired in '96. He was my second mentor. I'm glad I observed both and worked with them. And Brooks McLean, who has worked a lot in the relaxing retinectomy and published in AJO, and who was also with us in Mumbai. So the main thing is when you have a very severe traumatic PVR, where to do the circumferential or a vertical relaxing retinectomy. So it's critically important that all traction has to be relieved posterior to the retinectomy side. Sometimes there is membrane on the surface of the retina or behind the retina. So I usually make sure that the retinectomy site is diathermized so that you have hemostasis, because if you leave blood or there's some ooze, that blood also can be a cause of recurrent PVR. And already the challenge in traumatic retinal detachment is PVR. And here you see a publication by Mancino where the plain parscanavotectomy, the parscanavotectomy with the relaxing retinectomy, and see like a world map, the endolaser is done. And so they also compared when you do a buckling versus inferior rectectomy and a retinal detachment with PVR with the vitrectomy, and there was anatomically not much. So the buckle, if you have an inferior retinectomy done, you don't need a scleral buckle. So the decision to perform a relaxing retinotomy or a retinectomy, they usually made during the surgery after complete membrane removal. Even though you can plan it well, you can have the Steve Charles algorithm, and I also have a mental algorithm what I will do, like a game plan in a like a football match. Failure to extend retinotomy to the normal retina or to exercise the anterior flap may allow recurrent proliferation and contract to redetach retina, and that is the real challenge in a traumatic retinal detachment. And circumferential relaxing retinectomy are preferred to radial relaxing retinectomy that again depend on the case. So the tamponade following a relaxing retinectomy, the silicone study reported significantly higher rates of post-operative hypertony in gas-treated eyes compared with the siliconized injected eyes. So relaxing retinotomies and retinectomies in the management of retinal detachment with severe PVR, the anatomic and visual outcome at 6 months. You can see the retinal detachment of about 29%. Post-operatively, the best curve visual acuity improved in 23%, stable in 7%, and worse in 8 eyes at about 21%. So post-operative complications, recurrent retinal detachment in 18%, hypertony in 5%, and epimacular membrane in 8%. So this is the difficult part to explain to the patient, and that's why I'm sharing my experience. Here is a 65-year-old pseudophakic male where they follow total retinal detachment following a trauma. The scleral buckling was done, but he came with a recurrent retinal detachment with PVR with multiple retinal breaks, and you can see the retinal tears all around and the total fixed poles 360 degree. And I'm using retinal forceps to remove the membrane from the peripheral retina. And I thought in the beginning of the surgery, I will not do any relaxing retinotomy or a retinectomy. I was always sure that we can remove all membranes, but I'm now in between the surgery, I'm doing an endodrainage and doing fluid air exchange. When I do that, I see the subretinal air happening. That is indicating that the traction is not relieved because there are no membranes seen on the surface of retina or on the posterior surface. That means there's a thickening of retina because of the PVR. So I'm doing a relaxing retinectomy under air. And many people don't like to do that, but it's controversial. And I think few people in the world do, myself and Steve Charles. And you can see that retina is getting contracted. And that is because the retina is thick and contracted, it does not go to the contour of the back wall of the eye. And that's why you have to cut. And now I'm cutting the anterior retina all around 360 degree. The idea is to remove all the scar tissue with the retina in the periphery. And you see, after doing relaxing retinectomy, almost 360 degree, like a world map it is with the irregular cut retina. The idea was to keep the optic disc area and the macula attached, and then some part of retina, healthy retina around, so that you have attached retina to prevent recurrent detachment. So you see under the perfluorocarbon liquid, the retina is totally attached, and I've done 360 degree laser. And then I do PFCL, silicone oil exchange. In many eyes, I use Denziron. I don't have any financial interest, and you can see the preoperative patient with a total detachment and a postoperatively with attached macula, 636 with the oil on. And many times, if it is one eye and you remove the oil, you have to be ready to re-inject oil. Sometimes you remove the Denziron and use 5,000 centistrokes oil, or you remove, and in case there is early PVR happening as a post silicone oil removal, I think you have to make sure you enter again into the eye. So sometimes you operate 5 times, 6 times, 7 times traumatic PVR. So this is a second patient who the reason is actually a retinal redetachment, a belt buckle vitrectomy done earlier high myope, and you can see the myopic eye and a total retinal detachment with a recurrence. So I again remove all the membranes, and you can see that the total folding was there, and there was a posterior retinal break. I'm doing an endodrainage through the posterior retinal break, and you see the retina is getting attached. There are already collateral scar, and then in the periphery, the retina is thickened, and there are some scars because of the injury. So at present, I'm doing again relaxing retinectomy under air, and I'm also cutting the anterior retina again to because the retina is contracted, and you can see when I'm doing the anterior retinectomy, the retina is getting contracted. Sometimes you can go into an inoperable state where the entire retina curls over the optic disc, but here at least once the peripheral retina was cut, you can see the posterior retina was a little mobile, and then I'm using the retinal brush to segregate the retina and put it back and plastering against the choroid. And then under the PFCL, I use the laser, and then I do a PFCL oil exchange that I do when the silicone oil is through the infusion port, and then PFCL is removed through the bimanual viscous fluid injector. So this is the preoperative vision, and then that's the post-operative with about 6x60 vision after the oil removal. So take-home message: relaxing retinectomy or retinotomy can improve the curative effect of complicated retinal detachment in a trauma, post-trauma with PVR. However, there are potentially serious complications of these maneuvers that they should not be performed if less aggressive measures will suffice. So I want to remind everybody that Charles Kippens always mentioned, do the least to reattach the retina. So you should do everything possible to do the reattach the retina, but at the same time, do as much as minimum possible. And also you should remember, minimum should not be that you should be not do relaxing retinectomy where there is indicated, or if the retina is not going back. And if you don't cut the retina in the periphery, the retina will not settle. So the management in a given patient with a traumatic retinal detachment is a patient specific and cannot be generalized for all such cases. So the experience counts. So that's what I tell each patient, that in fact I've done, I think maybe I've done the maximum number of vitreoretinal surgeries in a tertiary care center for a trauma in the world. But still, whichever patient I operate, I don't know how the visual potential will be. So the first question patient asks, how will I get the vision? And they say, oh, you have operated so many patients, I will get vision. I said, no. There are two hurdles in vitreoretinal surgery for trauma. The first is anatomical success, and the second is the functional success. So that's where operating more these patients, I become spiritual, and I also become a vitreoretinal psychiatrist. So I learned to counsel the patient a lot before surgery. So I don't perform a retinectomy as a primary procedure, but I do think that this is effective approach, frequently underutilized, and with the appropriate experience, it can be extremely valuable technique for achieving better reattachment rate and improved vision in highly complicated traumatic retinal detachments. So as a vitreoretinal surgeon, one requires, this is what I learned from Dr. Badinath, a lion's heart, eagle's eyes, and a lady's fingers. You have to be gentle. Patience and stability of the mind is a must for very difficult cases for any vitreoretinal surgery. This is my 3 years, 3 generations of ophthalmology. And again, we are the 200 glorious years of modern ophthalmology. Thank you very much for the opportunity to Bangladesh Ophthalmic Society. Thank you, Professor Sharfuddin and Dr. Shams and everybody.
Thank you.
Thank
you
you.
have lion's heart, you have eagle's eye, and also lady's finger. That's why you
Yes.
have made everything easier.
So we are running short of time. We have more retina specialists here, including our respected Professor Ava Madam. So I am, and Dr. Geetali Saab, Professor Deepak Nath, Dr. Tariq Raja, and Dr. Amir Awan, all are retina specialists. So I want a quick comments from each panelist and speakers. Dr. Geetali Saab?
Yes.
Just comment
so
on,
much.
yes.
Yes, I forgot to thank the Ophthalmological Society of Bangladesh and also the Bangladesh Research Forum for inviting me. Such an honor to be involved in this excellent event. So congratulations, Prof. Natarajan, for the excellent presentation, and the results are, I think, fantastic. Most of the traumatic cases I manage, maybe not so many of them are as lucky. But yes, I do think that traumatic detachments are usually complicated cases and need individual approaches. And Also, it may occur both in blunt injury and also in penetrating or perforating injury, and maybe complicated with other pathologies aside from retinal detachment, such as vitreous hemorrhage, retinal dialysis, choroidal rupture, and in case of penetrating trauma, maybe there's IOFB and also luxated lens into the vitreous cavity. So there are a variety of cases. As you shown in your first case, there's suprachoroidal hemorrhage. That's also another difficulty, adds to the difficulty of the surgery. But I think especially in, as you pointed out, in these cases, especially the traumatic detachments, although more rare, but usually the cases are more severe, the penetrating trauma cases, there's a high risk of PVR. So I think the relaxing retinectomy would be very useful. I think in one journal, it's mentioned that almost 40% of cases would need relaxing retinotomies. So I think that's an approach I do frequently as well. And I think the important thing or important aspects of managing the traumatic detachment, of course, besides the careful history taking, the mechanism of trauma, whether there's a possibility of IUFBs or other complications, is to have a good imaging. I think we should employ the B-scan ultrasounds and also OCT, and we have to have a good view. So I think the addressing the factors that may obscure our view of the retina, such as a traumatic cataract and also hyphema, that has to be addressed first. I mean, we have to have a clear view of the retina, have a good microscope, good viewing system. And I think we have to be ready. I think every traumatic cases, at least I feel that way, is always daunting. I always try to anticipate the surprises, and we have to be ready with all the armamentarium. We have to be ready with the PFCLs or heavy fluids, endodiathermy, the dyes, and also forceps. And also, I think in my experience, I almost in all cases, I prefer silicone oil tamponade for the traumatic retinal detachment cases rather than gas. And regarding the timing also, I think when to do a vitrectomy for a traumatic retinal detachment depends. Of course, I think the preferable time is maybe up to 2 weeks, but I think in my hospital, sometimes it's difficult to do that fast. So, but I think within a month, maybe we should be able to treat these cases. Yes, I think that's my comment. Sorry if it's too long.
Thank you, Dr. Gitalisa, for your excellent comments. Dr. Tariq Rajali, please. Quick comments on this presentation.
Actually, there are tsunamis of webinar, but I feel that today's webinar was very much informative, and we have learned from cornea to retina through so many things. My few comments, or actually I have some questions to Dr. Natarajan. Sir, why did you do the retinectomy under here? That is my first question. Is it to reduce the retinectomy site, or why not under fluid? That is one question. Number two, if I do from PFCL to air and then silicone oil exchange, what is your comment? And number three, if somebody is a very difficult case of retinal detachment, if somebody wants to put the PFCL for a couple of days or a couple of weeks to flatten the retina, what is your comment, sir?
The first is under air. I like one because I can increase the intraocular pressure, and have, because of surface tension, the bleeding is less. For example, you are cutting blood vessels, and usually I diathermize and then do it. And the second is, you have to, before injecting the air, you should make sure all membranes are removed on the surface of the retina and on the back surface of the retina, under surface of the retina. So that case, you know that is because of the thickening of the retina is contracting. So in that case, I can do the extreme periphery, the retinectomy. So that's the reason I do it under the air. And I think under air, because I'm using the biome for last 30 years, so I have a wonderful visualization for long. So many times people don't want to do under eye because the visualization becomes a problem. And that's my what do you call unique approach I do. And I think I'm doing relaxing retinectomy in from last 34 years because of Joan, which taught us, and Maximus taught in 84. And that's how I remember Geeta's mother used to bring patients from Indonesia to Mumbai that time. And even when Dr. Raman Saman was there, he's no more now. He used to attend all the vitreous courses, which I used to do in 90s. So, and the second question is PFCL, air exchange you asked?
Yeah.
Yes. So the main thing is in the managing giant retinal tear or after doing a relaxing retinectomy, there's always a possibility of retina slipping. So if you under a PFCL, the retina is stable, and then when you have a 3-port injection through the infusion line and use the viscous fluid extract or a fluid needle in the dual mode, you'll be able to do silicone injection and removal of the PFCL without any change in alteration. But if there's some fine subretinal fluid is there, and under it there's a possibility of the retina slipping. That means sometimes some subretinal fluid can be there, and that can be the cause for recurrent PVR. And what is the third question?
If somebody wants to put some PFCL in the that is for a couple of days or weeks.
Yeah, there are publications where you can leave the PFCL for a week to 2 weeks. The only problem is the patient should be all the time lying down in a supine position, because if he walks around, it becomes emulsified and becomes small. And according, I think now if you have to use a PFCL, I use Denziron, because Denziron actually sinks down. So if you have a 360-degree retinectomy, and sometimes I also use sandwich technique, Denziron up to 2/3 of the eye and 1/3 of the eye with 1000 centistoscope. So and usually you don't see the meniscus difference, and the patient doesn't have any problem. And some people earlier, I think in 2000, when the heavy oils were there from various companies, Bosch and Lomb, Goider, the purification was a problem, so it was producing emulsification. And now the highly purified heavy oils are coming, so even you can mix 1000, not mix, you use a 2-layer sandwich technique, and where you can then remove the oil 3 months later, and if the eye is stable, you can leave the eye with the fluid only.
Thank you. Professor Deepak Nag, quick comments, please. Unmute yourself.
Unmute. Deepak, unmute yourself. Yes.
I think the good videos definitely for complex retinal disease. Actually, when the retina become funnel shaped RD, this is shortening of the retina, then I prefer only the relaxing retina. As Professor Natarajan rightly mentioned, that if you put PFCL and then PFCL air exchange or PFCL silicone exchange is not so easy, and there is every chance of slipping of this retina. So what I do, because it's most important thing is doing a good vitrectomy. And PBD is the very difficult thing, particularly in case of trauma, and if the patient is young, children, this type of patient. So I always put, this if there is not severe PBR changes and the retina is not shortened, I never go for relaxing retinectomy. I always put scleral band to make an artificial vitreous base, so that we don't need to go for the relaxing retinectomy. Relaxing retinectomy is another option, but it has some, it's very difficult as well. So I always put a scleral band and 2.5 mm band, so that I make an artificial vitreous base, and then I do the vitrectomy, and wants to do as much as possible case of phakic patient. So, and also I put silicone oil, and the silicone oil in this type of cases where there is a huge number of chances to become PVR changes, I always put 5000 CS silicone oil instead of 1000 or 1300 CS silicone oil.
Okay.
Thank you.
Okay.
Thank you, Professor Deepaknath. Dr. Amir Rahman, please, quick comments.
Just a quick comment. I think we are already getting late, and
yes.
Yeah, I think primary repair is very important. If it's properly done, things would be much easier for retinal colleagues to do the things. And early via referral is important. So if you look at the retina in earlier part of the injury, it's better after the repair. Other comment is about retinectomy. I think definitely I agree with Professor Natarajan. Retinectomy is a brilliant thing. Because sometimes what happens because of so much repair and things, it won't be possible to put scleral buckle or scleral band from the outside. And you may put more damage to the sclera, so retinectomy works very well. Another important thing, 2 to 3 surgeries. You have to tell your patients that it may not be one surgery to fix a problem. They may require more procedures. Coming to the tamponade, I think in my case, if it's a simpler retinal detachment, I may just put the gas. Usually I more often use gas, but if even slight complexity or moderate or more, it's better to use the silicone oil. And the last thing which I want to mention about heavy liquid, I think the question was asked about, there are few folks in the world who use heavy liquid routinely in simple retinal detachment. What they do is they just completely fill it. And after 2 to 3 weeks, they just remove the heavy liquid. It doesn't cause much inflammation if you leave it for shorter duration, and works really well. But usually I'm not fond of leaving it. I would rather go for gas or silicone oil. Thank you.
Thank you, Dr. Amir Rahman, for your nice presentation. I think there is a great war against the trauma, and we have won the war. Before ending the session with Professor Sharfuddin Ahmed's speech, I want to take a photograph. Please make a V sign because we have won the game.
Okay.
Won the war. Please.
Okay. V sign.
V sign. Thank you. So I'm requesting Professor Sharfuddin Ahmed to end the session with some valuable speech.
Thank you, Shams Muhammad Noman. You were the captain of this war, and you own on behalf of us. Professor Abha Hussain, Professor S. Natarajan, Professor Rajesh Sinha, Professor Parthu Pratim Bishas, Dr. Parthu Pratim Mojumdar, Parthu Bishas, Gitalisa, Priya Naran, and Professor Kader, Professor Tariq Rijali, and Professor Deepak Nag. And not the last one is Dr. Amir Rahman. Probably he's 11:30 now. Today in our country it is 10:30. It is 11:30 in your country. From Pakistan, Bangladesh, India, Indonesia, all are with us. I think this webinar has given a lot of idea to all the ophthalmologists and also all the residents who are attending our webinar. This type of webinar is the academic performance and as well as the latest techniques which are very much helpful to all the ophthalmologists of the world. I think this type of webinar should be continued, and you people who has given a lot of time in spite of your busy schedule to this webinar, I thank all of you, and I hope face to face we will see. But before that, during this COVID period, if necessary, we will request you. I hope all of you will again come with us in the same screen, in the same global village. And I hope Noman and Professor Kader, on behalf of Ophthalmological Society of Bangladesh and Bangladesh Ophthalmic Research Forum, they will always communicate with you, and we will again see you together. Thank you very much, and hope for your healthy life. Thank you very much.
Thank you, sir. Good night.
Good
Thank
night.
you. Good night.
Good night.
Thank you.
Thank you, madam.
Yes,
Abha, madam.
Thank you.
Thank you.
Good
Thank you very
night.
much.
Yes,
Have a
Rajesh
good-
is with us.
Hi, Natarajan.
Natarajan is here.
Who is
Priya is
she?
here.
Pardon?
Gitalisa, Amiraban. Okay, fine.
Who is
Thank
she?
you, Doctor.
My
She's a-
grandmother. Another 2 years
Your
grandmother.
grandmother. Who is
Ah,
102?
Ah,
102.
so lucky.
102
Madam.
years.
Really?
Madam, she is very
So
famous
nice.
internationally. She is very famous.
So nice. Natarajan, I am giving you one information that your Asian Pacific Academy Ophthalmic Trauma Society, we have already endorsed for full member in our Asia Pacific that is endorsed in EC.
Thank you.
Not associate member now.
Okay, great.
Oh,
Congratulations, congratulations, Natarajan sir.
Yes. And it will be final in the council, of course, but in the EC we have already endorsed.
I will request Rajesh Sinha to give me the email address of Indian Medical Council. Can you give me the address of email of the chairman of Indian Medical Council?
I'll do that, sir. I'll do that.
Thank you very much. Thank you.
Excellent
Also,
presentation,
Amit, you can
Partho.
give from Pakistan.
Thank you, madam.
You were not there at the beginning.
Okay.
Yeah, right.
Thank
And
you.
Priya,
Yes,
Priya is also very good.
Excellent. And also Professor
Excellent
Parthomati
presentation,
Majumdar.
Priya.
Yes,
And
everybody.
Tariq
Yes.
Raja directly mentioned one thing, that this webinar has given a lot of information to everyone. So very
Yes,
good.
yes.
Thank you very much.
Lot of residents are getting advantages, and we
it
will
will
have the
more than
second one.
6,000.
We will have the second one. I will declare later on.
Okay. Thank you very much.
Okay.
Thank you.
Thank you. Thank you.
Thank you.
Thank you,
Thank you,
everybody.
madam.
Good night.
Okay,
Good night.
thank you.
Good night.
Okay,
Thank
you.
you.
Good night to
Good night.
all.
Good
Stay
night.
healthy and stay safe.
Okay. Let fine will be given by Partho.
Lisa, see
Bye
you
bye,
in
Achi.
See you.
Namaste,
Bye-bye.
Achi.
Yeah.
Hopefully,
Thank you.
we will meet all of you in Bali next year.
Yes.
Yes.
We should have been hosting it this September, but yeah, everything's postponed now.
No, but
Okay.
you have
Next
applied
week.
for 2023, Gita.
Oh yes, the APO.
APO, right. I'm
But
telling that.
Yes,
Indonesian
hopefully we'll get it.
Ophthalmological Society will be in Bali.
The APOTS, actually, the trauma.
That Congress
society.
will be in Bali or in where it will be?